same ward is minimized. That is the basic intention of following this terminal cleaning. So you have to include the patient zone and also the wider area covering the entire room, whatever which has not been included in the routine cleaning when the patient is present. So here mostly you try to cover, you first start the general terminal cleaning with removing all the items which can be disposed of, and then sending the all the bedclothes and all the linen for reprocessing, or which has to be disposed have to be disposed, and then all the soiled, the windows and everything which have not been attended to when the patient was there, they have to be seen, and if there are any visible contamination, any body fluid spills, they have to be attended to. The curtains have to be removed and sent for laundering, and then all the non-critical equipment has to be again cleaned and reprocessed, and all the areas like whatever I told, the high touch and low touch and all the areas have to be cleaned, including the cupboards and the shelves which have not been routinely touched when the patient was there. Those have to be attended to. So linen handling again in the next presentation will be taught in detail, but all the whenever a patient is whenever the person who is handling the linen, they have to be given reusable rubber gloves before they start handling any soiled linen, and a gown and an app or a with a face mask has to be worn if there is any risk of splashing. And care has to be taken that the soiled linen never has to be carried against your body. It has to be kept away from the body, and then it has to be sent to the laundry where it has to be further processed. All the non-critical patient care equipment have to be again cleaned and disinfected with, as I said, alcohol wipes can be used, but taking into account the material compatibility of all these various items. And some big items like commode chairs, bedpans, they can be taken to the dirty areas, would be there in every ward, in every corridors. They can be cleaned there and then disinfected and then put to use for the next patients. Generally, we use 60 to 80% alcohol for cleaning all these thermometers, stethoscopes, and all these reprocessable devices. So spill management again, whenever there is an accidental spill, first the person who is concerned with attending to it should wear appropriate PPE, and then they confine the spill with an absorbent paper so that it absorbs most of the quantity of the spill is covered, and then you remove it and dispose it as an infectious waste, and then you clean the area thoroughly with a detergent and warm water solution, and finally you disinfect with a disinfectant like 5% chlorine bleach depending on the type of the spill. And for urine spills or vomits, you should use hypochlorine based disinfectants because it can cause chlorine fumes. So all this is a repetition. It's the same thing. The patient floor areas, how they have to be cleaned, not missing any areas. This is what I've told in the initial slides, that the figure of 8 fashion can be used not to miss any areas of the room. And toilets, as are more prone to more dirty, we have to increase the frequency of the cleaning. So just can you answer these two simple things? Like, risk of contamination is maximum in which of these location? I've told you initially is it in the corridors, outpatient clinics, a labor ward, or in the patient rooms? I heard one answer. Is it patient rooms? Why do you expect corridors to be more risky? Patient patient flow is more, but risk of contamination or risk of the organisms being present and then transmitting and spreading the infections, where can it occur more? Is it in the corridor or so this is based on the location which they have categorized. So where there is a chance of more body fluid spills or something, there is a risk of more. You just you have to increase labor wards or more. Which of these patients are more susceptible to infections? Yeah. Okay. So this coming to the specialized areas where we have to follow, it is almost the same, but the frequency of cleaning and the attention to minute details should be more in the specialized patient areas. So the specialized patient areas are those units which provide service to high dependency patients like in ICUs or intensive care units, ICCUs, where the patients with immunocompromised patients are housed, patients who undergo invasive procedures like in operation theaters, and patients who are exposed to body fluids like in labor and delivery wards and in burn units. So for the operating rooms, first we have to at the start of the day, it has to be made sure that the previous day everything was cleaned, the terminal cleaning was done, or else a full terminal cleaning, like whatever disposable things have to be removed, they have to be removed, they have to be uh, sent out, and then the patient care equipment which is not being stored routine in the patient operating room, once you get it inside the operating theater, they have to be thoroughly cleaned and disinfected once you get it into the operating theater for the first time in the morning. So before and after each procedure, like you have to remove all the used linen and surgical drapes, waste, like whatever I've told, for reprocessing and disposable, and you have to clean and disinfect all the high touch surfaces outside the surgical field, any visible body fluids outside the surgical field, anywhere, because we need to entirely take care of the entire operating room here. And then all the surfaces inside, high touch and low touch, inside the surgical field, and also on the, with special care to the top of the surgical lights, the reflective portion of the surgical lights, tourniquets, anesthesia trolley, operating table, everything has to be thoroughly cleaned and disinfected before the start. And after the final procedure, that is a terminal clean, again, you have to make sure that all the surfaces are clean. The sinks and the scrub and the utility areas and all the sinks are particularly attended to in cleaning and disinfection. And again, once the items which have been again taken out of the OT, they also have to be cleaned and disinfected before at the end of the day you are taking out them out to the operation theater. They also have to be cleaned and disinfected. Scheduled cleaning is what we devise. The schedule is devised by us. It is for the low touch surfaces which you don't attend to regularly during everyday cleaning. They could be including ceilings, walls, and inside of the cupboards, which are not routinely done in the daily basis. And all the operating for the operating rooms, it's better to have dedicated supplies of this cleaning, dedicated cleaning supplies, and also equipment. And all the mops and the the cloths which you use also could be, fresh mops should be used. For the SSD again, you have to follow the same principles that before and after use. This is not this is the sinks which are present in the SSDs. The sinks which are used for washing medical devices, they have to be, once before they are used and after they are used, they have to be properly cleaned. And all the high touch surfaces have to be done at least twice daily. And with the low touch surfaces, at least on a scheduled basis, which could be either weekly or monthly. Intensive care units also twice daily has to be done, attending to all the high touch as well as low touch surfaces. And once the patient is discharged or transferred to another area, and that particular areas also have to be thoroughly clean and made clean, disinfected, so that the next patient doesn't get any infection. Emergency departments, this is a risky area as the patients with trauma and lot of external injuries, they would come, and there is a lot of exposed body spills would be expected there. So it has to be cleaned at least once daily, and consultation has to be areas, the place where examination is being done, they have to be again done twice daily, and before each the patient is attended to, and after each patient is attended to, it has to be done. Hemodialysis units also, before and after each patient, all the disposable things have to be removed, cleaned, and special isolation units are where that immunocompromised patients are present. So again, you have to be very careful while cleaning all the high touch, low touch surfaces, and any visibly surface which is visibly contaminated with any body fluid has to be clean. So the transmission based precautions. What is transmission based precaution? Whenever a patient has got any infection with a resistant organism or something, some fastidious organism which is transmitted easily, and a multi-drug resistant organism, you need to follow some precautions so that you don't, uh, the infection doesn't get transmitted to the other patients or spread in the hospital. So isolation of those patients is recommended. If it's not possible to isolate the patients, all the patients, we do not have adequate space, then cohorting of the similar patients with similar organisms or similar, they can be cohorted and placed in one area so that they don't pose a risk to the other patients in the hospital or in this health center. The three types of transmission based precautions we routinely come across are airborne, contact, and droplet precautions based on the way the organism is transmitted. So the specific PPE has to be given, is required for all the the cleaning sessions. And once you start, these isolation areas should be cleaned at the last of the day, because you have to start with, generally what is the, if I have, if a same staff, cleaning staff have to attend to cleaning in a hospital, you have a tertiary care hospital where he has to go to the general wards, the oncology ward, and also a patient where patient or patients with MRSA are placed. So what is the order of cleaning? So you have some oncology wards and general wards. He has to go to an oncology ward and a general ward, and also he has to go to, he has to clean the patients where some MRSA patients are there. 5 patients are present in one room. He has to, in one ward. So where does he have to go first? Start the cleaning. General ward first. First we need to, first MRSA you telling? Oncology ward. Yes. Yeah, first we need to go to the, I mean, the post patients who are more susceptible. We need to clean those areas first, and then you go to the general ward. And last should be the place where there is a risk of transmission. So he has to last clean the patients where MRSA patients are present. Pardon? Transmission specific PP based on that, the how the infection is transmitted. If it is No, it's based on the what PPE you use. Whether it's a gown, a goggle, or a gloves, whatever is needed. Because if it's a droplet precaution, you cannot miss out on mask. So that has to be definitely used. Mask has to be used. For COVID patients, we need to use a mask, N95 mask. So for Clostridium difficile patients, again, we can use, I mean, the gloves can be used. So the way the infections are transmitted, based on that, the particular PPE definitely has to be worn and attended to. So airborne precautions, as I said, again, we need to use the PPE as such and then clean once daily. Uh, Keeping the doors obviously closed when you're following cleaning in the patients who are following the airborne precautions. So for Clostridium difficile, the normally we have been told that we need to use alcoholic hand scrub between each patients as a common part of hand hygiene. So if the Clostridium difficile patients are housed, then the spores are not killed by this disinfectant. So we have to use soap and water for hand hygiene. That is a difference when we are the patients where Clostridium difficile are there. So if you just use alcohol scrub and go in, it is doesn't work. You might end up spreading it. So better to use. You have to always use soap and water as a hand hygiene method. For environmental disinfection, also 0.5% sodium hypochlorite can be used in addition to enhanced hydrogen peroxide. So this is, I think, this is just a theoretical part of what is sterilization and disinfection. The most sturdy organisms, we are all aware that most susceptible are the enveloped viruses, followed by vegetative bacteria, followed by fungi like Candida, Cryptococcus, Mycobacteria, and the least susceptible are bacteria with spores and protozoa with cysts. So where autoclaving is not possible, we can use sterilants, chemical sterilants, which can kill the spores based on the exposure, prolonged exposure times. So we are aware of the three types of items: critical, semi-critical, and non-critical items. What are critical items? Mm. Critical items are instruments which can enter the inside the tissue, so they are at more risk. So we cannot take any chance of any organism being there. So directly we would be introducing the infection. So semi-critical is just the mucous membranes or a non-intact skin, or the items which come into contact with the mucous membranes or non-intact skin. So some things like even respiratory therapy, anesthesia equipment, endoscopes, and all these you are introducing, but they are not. They are just directly in contact with the mucosa only. They are not penetrating the tissues. So these are all semi-critical items. And the non-critical items, they just come in contact with the intact skin, like whatever the equipment which we use with alcohol, clean it with alcohol wipes, are all those non-critical items, like blood pressure cuffs, bedpans, etc. So based on this categorization of the equipment, we can use the type of disinfection and disinfectants which can be used. So the low level disinfectants are enough for non-critical items like ethyl alcohol, isopropyl alcohol at a concentration of 70 to 90%. Whereas for the semi-critical, you can use glutaraldehyde, hydrogen peroxide, or theptaldehyde. And for the critical items, ideal is autoclaving. But for the heat sensitive equipment which you cannot autoclave, the alternatives would be ethylene oxide sterilization, gas plasma sterilization, or by using liquid chemical sterilants like 2.4% glutaraldehyde based formulations or hydrogen peroxide at a higher concentration. So for the critical devices, ideally we have to sterilize either by heat autoclaving, if it's not possible, by using an alternative chemical liquid sterilant. For the semi-critical devices, high-level disinfection or intermediate-level disinfection, and there will be overlapping where the least would be the environmental surfaces. You can just do with sanitizing them. The Cryptosporidium parvum, if you are expecting the cysts of Cryptosporidium parvum, then the disinfection has to be done with either 6% and 7.5% hydrogen peroxide. So ethyl alcohol, glutaraldehyde, even 5.2% hypochlorite, all these disinfectants are not effective on the oocysts of Cryptosporidium parvum. Prions, there you might prions are those very the non-infectious proteinaceous infectious proteinaceous particles which are not killed even by normal autoclaving. So we need to use specialized procedures to get rid of the prions, which are a problem during mostly where neurosurgeries are being done. They have to be careful when the instruments are being cleaned and sterilized. The options are you have to immerse in 1% normal sodium hydroxide or 2% sodium hypochlorite for 1 hour and remove them and rinse with water, and then autoclave for 1 hour at 134 degrees centigrade, followed by the routine cleaning and routine sterilization. So this I think is a repetition. You might be easily telling these things. Oncology wards should be cleaned at any time of the day. First, before you start cleaning other areas. Last, after cleaning all the areas. A patient with Clostridium difficile diarrhea is present in the ward. What should be used for hand hygiene? Just when before enter the patient's room or and after leaving also. What do? You use the alcohol-based hand rub, soap and water. This is the only exception. We need to be careful when if you are suspecting any Clostridium difficile diarrhea. Soap and you have to clean your hands with soap and water before entering and leaving the room. Thank you. Endoscopes, sir. Formalin, I don't think anywhere they use formalin. They don't use, I think. Formalin, anyway, it is discouraged even for fumigation. Formalin efficacy, I think it is not supposed to be used. Then we should not be talking about the efficacy also. If it is not, but glutaraldehyde, I think, sir, it is available, isn't it?
See, because we are doing in daily practice, what is happening, even the pencils which they use, cautery pencils, they will keep it in the formalin chamber after cleaning with that. See what they are telling now. Surgeons, I am insisting so many times, and they don't want to listen. Arey, what you are telling, Baba? We are using time tested. We are telling you want, you are unnecessarily, you are upgrading your knowledge. You are poor, insisting on us. Time tested, formalin, time tested. That's what efficiency of. What is your experience? Formaldehyde tablets.
No,
See,
sir, I don't have any. I cannot tell, sir. I cannot tell. You are not supposed to use it.
you are not supposed to use. What is the formaldehyde? Earlier they used, for fumigation and all.
It's actually it is stopped now altogether. I think formalin is not at all used for fumigation also because it is carcinogenic. No?
It's a carcinogenic now. See, people are saying it's a time tested. We are using since 40 years. Yes, TSM is supplying formaldehyde. How can you say that no, for theater fumigation, TSM is supplying, all hospitals are supplied by this one. TSM is with formalin only. If it is abandoned, why they are supplying?
Actually, we should frame a guideline for
Yes,
this
yes.
and then implement this practice compulsory. Otherwise, it keeps on being followed. So we need to say as a microbiologist,
Yeah, that's what
it's our responsibility.
in all government hospitals. What happened?
Yeah.
Thank you, Dr. Ram Mohan, for your excellent presentation. Now we have Dr. Nagamani Madam from Gandhi Medical College, Professor and HOD. Madam is an eminent research and a microbiologist. I request Madam to give few words over this program, Madam. About the hospital.
Good morning, everyone. Actually, hospital infection control should have been in place since a long time. It has been overdue. So now I think even government is taken interest in that. And of course, if government takes interest, definitely it will be followed and then we'll be able to go ahead. So my plan is that we will make an infection control manual and then that will be uniform for all the state hospitals so that all of us will have the same protocols and then all of us can use the same procedures. So we will have SOPs. So for each and every procedure, we will make SOPs so that we will have standard SOPs that are to be followed and then controls. So controls for sterilization, like that. So and then so once we have a manual, so we'll write a policy, then we will write SOPs for each of these procedures for each thing. So sterilization of the equipment or sterilization in this CSSD. So what are the controls for sterilization? So all this we will make, and then actually I think we can circulate, and then if there are any modifications or if there is any local customization that can be done by the local people. But standard we will have one standard procedure for each and every, like uniformly for all government hospitals, uniformly for all the teaching hospitals, all the government hospitals. We will make that is my plan. So hopefully we will be able to proceed with this within a short period. I will take their help of Nizams and then we will come out with a manual and then circulate to all. So and then we'll have all these SOPs. And then maybe we can communicate the same thing to the government and then ask them to supply the same thing. Yeah, as you said, carbonization, formalization. So these are all the age-old methods. Even in Gandhi also we are following the same thing. Still all theaters are sterilized by formalin only, formalin fumigation only. Of course, cost factor is one thing, and then so that has to be taken care of by the government. So now that government is interested, we can expect, we can be more positive, and then we can hope that we'll be able to implement the proper infection control procedures. And it is the job of everyone. It is not just one person's job. It is a teamwork. So whatever we do, patient care altogether is always a teamwork, right from the administration to the class 4. All of us have to work together as a team and then own our jobs. Take pride in whatever we are doing. Don't think that we are doing it just for somebody else, but we should take it as an ownership. That ownership is very important, and the team spirit is very important, and then sustained. So whatever we do, so the procedures once we start, and then for some time there will be enthusiasm, and then slowly it dies down, and then again everything gets diluted. That should not be there. So that continuous sustenance of this enthusiasm and dedication should be there. So that way, if that is done, I think all of us will work together, and then we will be able to establish good infection control processes, and then achieve reduce this infections, hospital acquired infections. Thank you. And I congratulate Dr. Padmaja and her team and the microbiology department and Nizam's hospital. Teja, Dr. Teja, HOD, Dr. Vijay Tharma Teja is my colleague. We were all together in our post graduation. We did together. So I really congratulate the Department of Microbiology for the commendable job that they are doing. Actually, we have what is called as a state action plan on antimicrobial resistance. So that is one more thing. And once that is taken up, actually, hospital infection control, antimicrobial stewardship, everything would be a part of it. So all these things, if they can be worked, we are able to work on all these things. And then there has to be an integrated approach. So if we are able to do that, I think we'll be, and it's not very difficult. This is something which all of us are doing. To some extent, we are doing. But only thing is, standard protocols are not established, and standard procedures we are not following. So each one has one's own way, and then depending on whatever is available. Main thing I think is the availability of the resources. So within the limited resources that we have been trying to manage things somehow. But I hope that government will be more supportive, and then we will be able to do this better. Thank you very much for all the interest that you see here. So all of us should work together in a better understanding and a teamwork. Okay, thank you.
Thank you, madam, very much for your inspirational and motivational speech. And as madam said, uniform methodologies should be implemented. That is the basic aim of all of us who are here together. So we will try to work over it. And the next topic today is on Central Sterile Supply Department. It is a CSSD. So what is CSSD? CSSD plays a very important role in the prevention of healthcare associated infections which have been associated with the inappropriate disinfection of reusable objects. So a brief history about CSSD. In 1928, it was first coined by American College of Surgeons, CSSD. In 1942, World War II, Cairo British SDS unit, it was termed as SDS unit. In 1955, Cambridge Military Hospital regular CSSD was first coined in UK. And in 1965, first CSSD in India was in Safdarajan Hospital. So I think this history, we need to know a brief history of from where the CSSD existed. What is the definition of CSSD? CSSD is a term that denotes the services where you receive, process, prepare, control, and distribute the instruments, textiles, and biomedical devices to all the departments of the hospital, including wards, OPDs, and OTs, with the goal of providing a safe input to be used with the patient. The main objectives of CSSD are, I think you know thoroughly about this. We need to provide a service and quality care to improve the patient care and maintain high standards of medical practice, and it is responsible for collecting and receiving the objects and devices used during the patient care and for processing, storing, and distributing them throughout the hospital. And even we need to maintain quality control parameters for all the methods of sterilization, whatever we do in our CSST, that is very important. And we need to document the effectiveness of each method. So even to collaborate with hospital administration is also important. Why? Because to protect personnel from infections or accidents and to provide a safe environment for employees. So these are all the objectives of CSSTs we need to create and implement. Size and location of CSST, usually it should be located near the operation theaters, emergency departments and OPDs. Size of the CSST depends on the number of beds in the hospital and future expansion. Area required for hospitals with more than 300 beds, a minimum of 7 square feet per bed is required. For 1500 bedded hospital, Nizam's Institute of Medical Sciences is a 15 bedded hospital, 1500 bedded hospital. So actually, as per the protocol, we need 10,500 square feet. But it's not easy to have a space at that point. We need to slowly develop these, search for the space and then try to establish. This is the CSST layout. To give you an idea, I have provided this. If you see the entry for it should be in 3 zones. One is dirty zone, second is a soiled zone, and third will be second will be a clean zone, third will be a sterile zone. Okay, so there should be always a barrier between the dirty zone and also the clean zone. So you cannot you need to make an entry first into the dirty zone with all your equipment, whatever you are getting from the surgical side OTs or wherever you are getting. So a dumb waiter utility should be provided for all the hospitals. If the dumb waiter utility is there, it will be in the form of a lift. So you can get directly from those areas into the CSSD area. That sort of provision also should be there, provided to us. But some corporate hospitals have this facility of dumb waiter utility, where you receive the used instrument soaked in the required disinfectant, and then they will come up to CSSD. That kind of facility should be provided. And then every instrument should be soaked and sent. You cannot send a dry instrument. Please remember that. If it happens, try to instruct your surgeons, don't send like that. Why? Because the matter which it sticks to the instruments, all the proteinaceous matter will be dried off. So once when it is dried off, you cannot wash it. So you have to soak and send the instruments to the CSSD. That is an important point we have to note. Otherwise, what happens during cleaning process, it will not be in a correct way, the cleansing will not be done. Every time, whenever in the dirty zone, you should have 2 sinks located. One sink you have to use for cleaning the instruments, the other sink you have to clean. Second time, the same instruments should be re-cleansed once again. And cleaning is the first important step that you need to follow whenever you send all the instruments to CSSD. Make sure that thorough cleaning is done. And then these instruments will go into the clean zone, okay, where there will be packing, everything will be done, and then this material will be passed into the sterile zone later once after it is sterilized through your particular autoclaves, steam sterilizers or ETO sterilizers or plasma sterilizers, whatever you use in your hospitals. So the entry and exit point should be different for the CSSD. Entry and exit cannot be the same. Please remember that. You can share your experiences of your own CSSD later, how they are in your hospitals. So design considerations, restricted or controlled access should be there for all the CSSDs. Unidirectional workflow, progressing from dirty to clean to sterile areas. Controlled airflow should be there with positive air pressure from clean to dirty areas. Containment of steam and moisture, preventing potential contamination of stored sterile articles should be followed. Building and layout details that would facilitate easy cleaning. Separate entry and exit for soiled, clean and sterile goods should be followed. And the separation of staff working in 3 different areas should be separately appointed. So you need even adequate number of staff working in CSSD. This is very much essential. You cannot run with one staff of CSSD. You need at least based on your facility, like if it is a PHC, if it is a CHC, district hospital, area hospital, there are certain specifications where you need to have enough number of CSSD personnel to work there. What are the responsibilities of the CSSD manager? Develop a procedure manual to document SOPs for all the processes carried out in CSSD. The manual should be approved by the Hospital Infection Control Committee members and reviewed at regular intervals. Oversee the various processes carried out in the department, namely cleaning, decontamination, disinfection, wrapping, sterilization, storage, and distribution. You have to monitor the process by use of different methods such as physical, chemical, and bacteriological according to the policy of the healthcare facilities. And you need to ensure technical maintenance of all this equipment according to manufacturer's instructions. So you need to check over these instruments whether they are working or not. If they are not working, try to immediately inform the administration and get the repair done instead of keeping them wasted. Report any defect to the administration, maintenance, infection control, and other appropriate personnel. So you need even appropriate people to whom to report. This should be known to all of us. And even you need to ensure appropriate separation of clean and dirty areas, maintain complete records of each sterilizer run, and preserve records as per standard recommendations. So once you see our CSSD, you can see all this documentation if you visit CSSD today. Organized collection of all outdated sterile units at regular intervals, and communicate as needed with the IPC team, the nursing services, the OT, infection prevention and control program, the hospital transport service, pharmacy service, maintenance, and other appropriate services. So this is the workflow, how it should be in CSSD. Soil zone should be having a physical barrier from the clean zone and from sterile zone. So CSSD follows an unidirectional flow concept, that is dirty zone to clean zone to sterile zone, but never in opposite directions. Our system, if the adequate space is there, we can plan for this kind of infrastructure and then we can build it. So this is how we need to plan. But majority of our CSSDs would not have this plan, of course. So zoning, as I said earlier, this is divided into 3 zones. Reception, inspection, and decontamination is the first zone. And here the items are received, disassembled, cleaned, and decontaminated by means of manual or mechanical processes. And zone 2 is involved with assembly and packing. Here clean items are received and inspected, replaced if necessary, assembled, packed, and labeled for further processing like sterilization. And zone 3 will be sterilized items are received and stored until it is time for them to be issued. Soil zone, in this zone, the microbial load and organic matter of instruments and medical devices are reduced. This area should be separated by a physical barrier from other areas. As I said earlier, it is important to have a physical separation. Why? Because to avoid the transport of aerosols, droplets, and dust particles from the dirty to clean area through the air currents. All air from this sector should be expelled to the exterior, and movement of the people should be restricted and it should be controlled. Only adequate personnel should enter this area. So all should not enter and make the area clumsy. Fans of any type should not be used within the area. Windows should be closed permanently. Clean zone, how it should be? This is the area for conditioning, packing, preparation, and sterilization of the material. Only completely clean, dry objects should enter this area. Here, instruments and devices should be checked in order to safeguard the cleaning process, and it should be under positive pressure. Humidity should be at 30 to 60%, and there should be minimum of 10 air exchanges per hour, and the ideal temperature should be about 22 degrees centigrade, should not exceed 24. What is the sterile area? Where the area wrapped sterile devices or instruments should enter this area. When the sterile pack should be placed on open shelves, we should have proper storage material also to preserve all this sterile package material. This area should be ventilated with at least 2 air changes per hour, and temperature should be at 18 to 25 degrees centigrade, and the environmental humidity should be between 35 to 50%, and the sterile packages should be stored at a minimum distance of 30 centimeters from the floor. And the movement of people is completely prohibited and only authorized. Adequately dressed personnel should enter the area. So if you follow all these precautions, it will be absolutely perfect. Actually, we also know this point, but still the areas remain with many people entering in and out. How do you monitor the sterilization process? You use a chemical indicator. Quality of sterilized goods are accessed by the use of the chemical indicators. And a chemical indicator is used with every pack that is sterilized. And for steam sterilizer, here class 5 strips are used in each load, which is sensitive to 3 parameters like temperature and pressure. And even gas sterilizer, a dosimeter is to be used in each bag, which is sensitive to 3 parameters, time, temperature, and gas dosage. Mechanical controls, a time, temperature, and pressure chart is maintained in each sterilizer. And bovidic test also should be done to determine the adequacy of air removal, whether it is removed properly from the chamber or not. You need to do this bovidic test load during the pre-vacuum stage, done daily, and steam quality before starting the cycle. Penetration time is 12 minutes, holding time is 12 minutes, and safety time is 6 minutes. And the biological sterilizer that we are using in our institute in CSSD is Bacillus stearothermophilus. So I'll show you the picture how if it is a passed test and what is a failure test color. And the discard of CSSD items, they should be discarded in red bags. We are supposed to discard only into red bags, and these bags are taken to CSSD before 10 a.m. and placed from CSSD before 10 a.m. and placed on a trolley. The trolley with all the bags placed on its autoclave, these are then sorted, washed, replaced, autoclaved, and supplied to the wards. These are the few pictures which I have collected from different major prominent websites, like how it should be. The transport trolley should be in this way. And this is a picture showing the manual decontamination sinks provision for water guns and air guns. Why do we use these water guns and air guns? Because we have crevices in the instruments. So those crevices cannot be washed with a mechanical manual cleaning. So we need to use this kind of air guns or water guns to spill out all the material sticking in that crevices area. Otherwise, you cannot reach that area and clean it. Is it clear? Yes. So these are termed as air guns or water guns. Of course, we don't have these facilities, but at least we should try now for this to procure them. In all India Institute of Medical Sciences, this provision is there in the established AIMS institutes. So these are ultrasonic cleaners. It is ultrasonic washer is a machine used for cleaning surgical instruments. It converts high frequency sound waves into mechanical vibration that produces small bubbles that burst on the internal surfaces of the instruments, and it dislodges the waste particles. And these are how the washer disinfectors should be available, and the drying cabinets are also available separately. If they are all imported machines, they are all in high cost, but if they are local made, the cost price goes reduced. Sterilization methods, as you know, autoclave, it is a steam under pressure, is the most cost effective method, and I think all the hospitals will be having with the provision of autoclave, where the steam is generated and a temperature of 121 degrees centigrade is maintained under 15 pounds of pressure. An exposure of 20 minutes is required for sterilization. And chemical sterilization, we use ETO. ETO sterilizer is available at NIMS. And I think Dr. Ram Mohan sir has showed you that heat sensitive instruments can be gone with sterilization with the ETO. And flash sterilization is a special type of autoclave that has a very short sterilization cycle of about 3 to 5 minutes because of its ability to raise the temperature to 132 degrees centigrade. And there are many hospitals where there are plasma sterilizers also nowadays. But plasma sterilizers, they cannot penetrate the heat very much. But if you have an emergency purpose to get the instrument sterilized immediately, it serves the purpose. plasma sterilizer. We don't have plasma sterilizer, but all our clinicians as surgeons are requesting for plasma sterilizer. So these are the gravity sterilizers that are available at NIMS. And before sterilization, the pack will have the blue color. After the sterilization is successful, it turns into black color. And the next picture, batch monitoring is also, there is a color code. It will be pink before the sterilization. It will turn green once the total batch is sterilized. I think these things you can see once you visit CSSD, you will have idea. And next, these are the biological indicators that are used for steam sterilizers and ETO sterilizers. I have represented the topmost picture is the purple indicates test passed and the yellow indicates the test failed. And the biological indicator for ETO sterilization is the below picture, where green indicates the test passed and yellow indicates the test failed. So running the controls is very important in CSSD. Otherwise, it serves no purpose. We should not supply the equipment as such without doing controls, without putting up controls. ETO sterilizer, the items like cardiac catheters or thermosensitive can be sterilized by steam. Such items are sterilized by ETO, gas sterilization. It is an expensive and toxic gas is released. It is absolutely necessary to ensure that these items are made free of gas molecules and before using them on the patient. This is achieved by subjecting the items to forced ventilation. So even when you do sterilization with this method, please ensure that these all items are made free of those gas molecules. And for this, you should subject all the items to forced ventilation for some time. And the entire cycle may take about 8 to 12 hours. And this is how the ETO sterilizer is at NIMS. And the picture, this is an open door which I have shown there. You can load the material into that. And the next picture is before ETO sterilization, it will be blue color. Once after ETO sterilization is successful, it will turn into a sea green color. It's a kind of olive green color. So next part is linen. Linen, I think you all know, it includes all the textile used in hospitals, including mattress, bed cover, pillow, covers, bed sheets, towels, blankets, screen, curtains, doctor's coat, table cloths, everything. All this linen, cotton is the most preferred and frequently used material. It is cheaper and more comfortable. Laundry services, hospital laundry deals with linen, which is soiled from various body fluids like blood, body fluids, urine, feces, all will be there on this linen. So they should be thoroughly washed. This type of linen required to be disinfected and serviced before putting them into washing machines. You cannot directly place this blood and body fluids directly into washing machines. You have to clean them first, soak them into hot water, and then you need to put them into washing machines. Laundry services include wide range of activities pertaining to procurement, washing, cleaning, disinfection, and distribution of clean linen to hospital, IP, and OP areas. Linen and laundry, you have to follow hand hygiene practices and personal protective equipment. Why? Because all this linen will be carried with infectious material. You need to follow standard precautions at that point of time. And soiled linen should be placed in a leak-proof bag and treated with 1% hypochlorite spray, packed and sent to laundry. Directly, please don't send the linen as such. Try to treat it with 1% hypochlorite and then you have to send to laundry. If it is a machine wash, wash at 60 to 90 degrees with laundry detergent followed by soaking in 0.1% sodium hypochlorite for approximately 30 minutes and dry thoroughly. If there is no machine wash in your facility, soak the linen in hot water with a soap or detergent in a wide mouth drum. So use wide mouth drums, stir with a stick, avoiding splashes, followed by soaking in 0.1% sodium hypochlorite for 30 minutes. Then rinse with clean water and then dry them in sunlight. So these practices should be followed, and you also need to make a visit to linen and laundry also. This is also important as a part of the plan. And this is the scheduled cleaning of linen in inpatient wards monthly, annually, and after patient transfer. I have displayed here. So linen and laundry management you have to window blinds and bed curtains should be cleaned monthly. If it is window curtains, annually they should be cleaned. After patient transfer or discharge, remove privacy and window curtains for laundering and then send to the laundry for washing. Workflow of linen and laundry at NIMS. This is the workflow how it is done. Washing of all linen with plain water in washing machine for 30 minutes. Washing with chemicals for 40 minutes in washing machine. Washing with plain water for 30 minutes. Spinning it for 30 minutes. Drying it for 30 minutes. And then ironing. This is the process how it is being followed. Type and quantity of linen received at NIMS is type of linen received cotton. Quantity is 3,000 to 5,000 bed sheets are received from 16 OTs. This is what we are, how the material quantity is being received. So what is a barrier laundry system? With a barrier laundry, a wall separates dirty linen from clean linen. Clean and dirty linen never come into contact with each other. So cross contamination should be avoided. Like how you frame a structure for CSST, in a similar way, even in laundry also, you need to have a barrier between the clean linen and also the dirty linen. I have shown here a barrier laundry system where a barrier washer extractor has two doors located. So on the other side, if you put the material, the other side you have to receive this kind of system I have seen in CMC Vellore. This provision is available there. So I think these latest infrastructure should be established. That is all the mechanized laundry system should be there. Dirty linen is loaded into machine in one room and the clean linen is then unloaded in the another side of the room. I think you understood, no? On one side you put it and the other side you remove all the linen. Did you come across anywhere this kind of system? You have seen it? No. Okay. So laundry machine, this is the laundry machine at NIMS which we have. And the dryer is also available at NIMS. So with these facilities, we are performing regularly all the linen and laundry, and documentation is also followed regularly. So documentation is very important. What is the load, how much you have done the washing. Everywhere documentation is essential. Even for CSSD also, you need to document what are the number of packs that you have received from each OTs. What are the materials you have received? So are they being supplied in a correct way back to them? Or you are missing some of the instruments? That also can be possible. So you need to put, yesterday Dr. Gangadhar sir said that you need to have 5 packs in your hand. Okay, one pack will be already within the CSSD and 2 packs will go to the OT and 2 packs will be outside for the emergency purpose. So you need to have these 5 package systems readily available for each OTs. I think you know gloving policy should be followed everywhere. Standard precautions are must for hand hygiene and also gloving policy. Wearing gloves does not substitute hand hygiene, and decontamination should always be done before wearing gloves and after removal of gloves, as gloves may have invisible defects which may allow the transmission of microorganisms. So I thank you all for giving me this opportunity. Thank you. I invite the next speaker. Krishna is an infection control nurse in our hospital. He is in charge of respiratory intensive care unit, and he works along with our team, infection control committee team. So today he is going to give his lecture on outbreak management. Thank you.
Thank you, madam. Good morning, all of you. It's my pleasure to present a topic in front of all you eminent clinicians. So, these experience and eras tells us that always there is a outbreak in the healthcare system. But the way of dealing has changed. Previously, they do not have any protocols or any standard instructions. But upcoming, this new technology has taught us and given us, and it is very, very reachable to us to deal any kind of these outbreaks. So generally, these outbreaks are generally initially found out by a nurse or a clinician or a microbiologist during various studies or during rounds. So we play a major role to find out any outbreak and to communicate it to the higher authorities. And also, these outbreaks generally, for any kind, just to identify, not only to know the disease condition, but its progress level, we can make out easily. So this makes us first priority to identify any kind of outbreaks. Identification of it outbreak is not only cost involving, but also institutional image. So to protect our institute, we need to be very vigilant in finding out this outbreak. So to define the outbreak, it's nothing but an unusual occurrence of a disease or health-related illness in the community or in the region. Maybe really excess than the occurrence. So anything that is more than the line, that is called as outbreak. On epidemic or outbreak. Outbreak is nothing but at a smaller level of this epidemic is called as outbreak. So to understand this outbreak, let us come see these three terminologies: endemic, epidemic, and pandemic. Endemic is nothing but there is a transmission, but the number of cases remains in the control. But in the epidemic, there is a number of cases more, but it is confined to the one geographic area or one particular area. Coming to the pandemic, like corona, it is spreading to all over almost all the continents. There are some objectives of outbreak. The main objectives of outbreaks are controlling the outbreak, prevention of its further transmission, providing the statutorily mandated services, and to strengthen the surveillance activities, advancement of the knowledge, and providing training opportunities. These are the objectives of outbreak. There are two types of outbreaks. One is community related outbreaks and second one is healthcare related outbreaks. Community related outbreaks are generally related to food and waterborne related outbreaks like measles, Ebola, all these are. And healthcare related outbreaks are like when there are more than 2 cases, there are epidemiologically common, or infection occur over the level of background rate, or when there is an unusual bacteria found in the patient that gives rise to the outbreak in the healthcare system. To know this outbreak, the magnitude of the outbreak, we need to have an investigation on the outbreak. The purpose of outbreak is to investigate and to prevent the further transmission of the disease. The main objectives are identifying the agent, finding the source of infections by means of place, time, person, and also formulating a recommendation to prevent the transmission. There are steps involving in the management of outbreak. One is the recognition of an outbreak, prompt notification of a disease, doing search and research, and implementation of the recommendations. If we come to the first step, look for any possible indication for outbreak. First, we have to see any indication for outbreak, like patient having more fever or doing abnormal. There is a problem with the values of the TLC counts and all. Then we have to primarily investigate person, place, or site, or pathogen. Primary, a rough, thorough investigation should be done on the patient. Next one is defining the outbreak related to time, person, place, where it has occurred, in which ward it is occurred, on which day the surgery has performed, or the patients are really sick. So we have to do determination. And also we have to identify the magnitude of the problem, and if the magnitude is very bad, at least if there is no standard rules, try to impose some general precautions. immediate precautions. Then verification of diagnosis, each and every case must be verified and rechecked for to fit into this definition. Then after the confirmation, we have to after the verification, we have to confirm this outbreak. Once the outbreak is confirmed, immediately it has to be notified to the higher authorities, especially to the concerned department involved, personnel, and the hospital administration department. Once it is done, we have to do some research and background work on the outbreak. We have to search for the additional cases, and both in the clinical way and also doing some records, microbiological record verification, and also we have to line list every case pertaining to the time, place, and also develop a epidemic curve. This really guides us how the magnitude is, how the serious problem is. So we have to develop a epidemic curve, and we have to analyze the data based on the common features. Does all these questions are fitting into it, or is there any background other problem for this question? So we have to do the background verification and analysis of the data. And if you are doing any cohort study or case control study or microbiological study, we have to test the hypothesis. Hypothesis, I think all of us are known that we assumption whether this attainable or it is same what we are thinking. Once the case research is done, once we are find out, at least we have to impose some immediate measures. These immediate measures really help in controlling the progression of the disease. So the investigations, these measures include strict hand washing, at least strict hand washing till we come to a conclusion. We have to insist for the hand washing and intensification of environmental cleaning and hygienic procedures, adherence to aseptic protocols, and strengthening of disinfection and sterilization. And there should be a microbiological study should be carried out to identify the source and modes of transmission, and there should be a culture should be obtained from the different other sites of the patients, different personnel involved, and the environmental samples should be taken. The care must be taken while drawing the sample, taking the sample, culture samples. So these all are the some agent-based precautions. Like when there is a cross transmission, there should be patient under isolation and various precautions should be used. If there is a contact precautions, there should be a hand hygiene, hand washing, and gloves should be used. If there is a airborne related infections, patients should be under isolation and appropriate ventilation should be provided. And if it is a waterborne related infection, there should be a checking of the water supply. If there is all liquids must be checked. If there is a expiry date or kind of thing, that batch type of medicines must be checked, and use of disposable items should be recommended. If it is a foodborne related, the at-risk food must be avoided. Fourth and final step is implementation of the specific measures. This should be, once we have come to a conclusion, if the general measures are not working out, still need of any further investigations, we have to implement this specific measures. For this, we have to monitor the further cases and effectiveness of controlling measures, and we have to form a report and submit to the HICC, Infection Control Committee, for the and department that are involved in the outbreak, and also for the administration. These specific control measures are include identification and elimination of contaminated products, modification of nursing procedures. Like if you have come across with a MRSA patients, nursing procedure, your procedures can be modified, like cohorting the patient. At least if you don't have a place, separate room, put the patient into one corner of the ward and ask the nurses to address the patient, to help the patient at the end by after giving all this patient's treatment. If possible, try to assign only that particular nurse to that MRSA patients. Do not mix the nurse with the MRSA with the non-MRSA patients. So these nursing procedures can be modified. And also rectification of lacks in the clinical procedures or techniques. There will be a hurry in the procedures. Some of the surgeons are not bothered about the disinfection, cleaning else. Just get the instrument. So there what we can do, like adopting the plasma or flash sterilization matter of 5 minutes. So if you can insist that can be done. Then there should be an evaluation of your measures. Whatever the control measures you have taken, you have to evaluate. It should be evaluated by a continued follow-up of cases after the outbreak, as well as the microbiological study. continuous follow-up of the cases and microbiological study. Through this, we can evaluate. And these measures are said effective only the cases start declining or it comes to a previous level. This is an epidemic curve that we are talking about. The first curve says there is no interventions and the cases are going up. This is a very bad sign for any healthcare system. And the second one is the red one depicts the without interventions and the green one with interventions. So the peak of the curve is always down with the interventions, and these interventions should be taken care as early as possible. When we say that outbreak is end, so when we declare that outbreak is end, when there no more susceptible individuals, no more exposure to the source, no more source of contaminants, such as if at all any poisonous food contaminated, if the food is completely consumed, if there is no more food is left over, then they can declare. And the individuals are decreased to their susceptibility, maybe because of natural immunity or the immunization or because of some using barrier techniques. And when there is a less pathogen becoming less virulent, then we can declare the outbreak. These all are the guests that India always have outbreaks in different diseases in different years. We can see that this one, diarrhea and food poisoning are the most common guest in India. And this is the latest outbreak that we had in our Telangana. Luckily, fortunately, as soon as the patient, almost we received 17 cases, 17 or 20 cases to Nizams, and our HICC identified one sample, MRSA. Soon after the identification, they implemented and circulated this guidelines for MRSA treatment. So they advise the strict hand washing technique, use of barrier techniques like cohorting the patient, use of single disposable items, and proper disinfection of those items, and freshly prepared 1% sodium hypochlorite for the environmental cleaning, limiting the number of staff, and also no attenders policy. And these are some of the measures that are given by the HICC of NIMS to deal with this previous outbreak. To conclude, performing surveillance and monitoring trends are important for detecting any outbreaks. Investigating outbreaks and elimination of source, providing technical assistance and education to the medical community, designing and implementing a special epidemiological studies are important for any controlling of outbreaks. So this identification and controlling of outbreak is completely in our hands. If you are very vigilant, notify it, identify it, and try to get some action. So the mother of modern nursing said that you should not cause any harm to the sick. Our first priority, first motto when you put your apron or step on your shoulder, you should feel that I should not cause any harm to my patient. If that is our motto, we can prevent any kind of outbreaks. Thank you.
మీరు నాకు షేర్ చేయండి. అసలు ఎవరికి ఐడియా లేదు. I invite Dr. Padmaja Madam. She is professor and head of anesthesia department to give her lecture on VAP bundle precautions, ventilator associated pneumonia bundle precautions.
డార్క్ చేసేవా ఇటుంది ఫాంట్ Good morning, everyone. I think continuing with this very important aspect of our healthcare, that is infection control, we will be dealing with ventilator-associated pneumonias. I think a lot of times we intubate patients and keep them on a ventilator for very important reasons, like either they are unconscious and require some airway protection, or they have some underlying pulmonary disease for which they are intubated and put on ventilator. After having successfully managed this part of ventilation, one thing that really sinks us down is the pneumonia, ventilator associated pneumonia. You find a new patch on the X ray, which is so difficult to treat and has multi drug resistant organisms. So, this is something that is preventable and difficult to manage. So, probably prevention is always easier than managing. So, we'll start with the ventilator associated pneumonias. So, if you look at the nosocomial infections in the ICU, pneumonia is the second common infection that affects the critically ill patients. And almost 27% of the patients are found to have this nosocomial infections and pneumonia. And 86% of these nosocomial pneumonias occur in mechanically ventilated patients. So that means this forms a major chunk of our hospital associated infections. So this is termed as the ventilator associated pneumonia. If you look at hospital acquired pneumonia, that is not really related to the ventilator as such. It occurs, anything that occurs 48 hours or after the admission to the hospital is known as a hospital acquired pneumonia. And again, this is one of the common nosocomial infections that we see. So this would include even those patients who are not being managed on a ventilator. So pneumonia is common, and among that, ventilator-associated pneumonia is one of the common infections that we see in the critically ill patients. Now, why healthcare-associated pneumonia? First thing is, if the patient has been hospitalized in any acute care facility for more than 2 days, then these patients are at risk for developing pneumonia. Especially, so healthcare associated pneumonia includes not only those hospitalized patients, but also patients who are in nursing home or in long term care. And anyone who's receiving antibiotic therapy or chemotherapy or wound care within the last 30 days has a high risk for developing this hospital acquired associated pneumonias. And especially those who are receiving dialysis are also at higher risk. Now, if you see the number of patients who are undergoing chemotherapy or undergoing dialysis, this is steadily increasing. So, the risk of having a hospital or healthcare associated pneumonia is going to continue to increase, because as we extend our care to sicker patients, these sicker patients are more likely to develop healthcare associated pneumonias. So ventilator associated pneumonia is something that is defined as any pneumonia that occurs 48 hours after the endotracheal intubation. And this is again subcategorized into early onset, something that occurs within the first 96 hours. And usually the reason why we need to know about the onset is because the early onset pneumonias are caused by antibiotic sensitive community acquired organisms, whereas the late onset, that is anything that occurs after 96 hours, is more due to some multi drug resistant pathogens. So that is the reason why it's important for us to also look into the onset of the ventilator associated pneumonias when we are considering management of these. Now, why 48 hours? Because this window is important, because there may be infections that are already incubating in the patient which are not really related to the ventilator. So they may usually these manifest within the 48 hours. So anything that occurs after 48 hours, you can attribute it to the ventilators. Now, why are intubated patients at risk for pneumonia? So obviously, you know that there is a high chance of invasion of the lung parenchyma or the lower respiratory tract when the patient is intubated, because you're breaching the natural defenses of the patient. So the tube is going to lie across the vocal cord, so the natural defenses are breached. So there is more chance that the lower respiratory tract is going to be incubated by organisms. So mostly these trickling of the organisms into the lower respiratory tract is either from the oral cavity or from the gastric uh, aspirates. So these are the major sources, the aspiration of the oropharyngeal fluids. And so usually the colonization of the oropharyngeal cavity by organisms is one of the common causes for ventilator associated pneumonias. And also, like because there is an endotracheal tube and you are artificially ventilating these patients, there is a direct access for these organisms into the lower respiratory tract. So any contamination of the medical equipment is also likely to result in ventilator associated pneumonias. And sometimes there is a hematogenous spread also. So if you look at the source of these organisms, you can understand that these are easily preventable sources. There are some things that are beyond our hands, and those are the host factors. So age more than 60, severe illness, either polytrauma or malnutrition or renal failure, these are host factors that increase the risk for the patient to develop a infection. So when these colonized organisms reach the lower infected tract, they're going to cause infection or not depends a lot on the host factors. So any patient with a chronic underlying lung disease or previous antibiotic therapy, especially with broad spectrum antibiotics, is at risk for developing more severe infections. And also, when patients are re-intubated or intubated for a longer period, the risk increases. And other risk factors that are iatrogenic are frequent changes in the ventilatory circuits or prolonged paralysis. So the greatest risk for ventilator associated pneumonias is within the first 5 days. And the other risk factors are like the increased risk of external colonization. So this colonization increases in the intensive care settings because of the excessive use of the antimicrobial agents. And you must be listening to this in the last few hours that as we use more and more antimicrobial organ agents, you are going to increase the resistant organisms growth in other areas. And other preventable things are contaminated hands and contaminated equipment. Sometimes the colonization happens from within, like aspiration of the oropharyngeal or gastrointestinal secretions. And iatrogenically, we also sometimes inoculate directly into the endotracheal tube. And this I'll tell you why in a couple of minutes. Or inhalation of bacteria or hematogenous spread. So these are the internal colonization. Now, how does the oropharyngeal colonization happens? So usually because of the poor dental hygiene. Obviously, if the patient is on a ventilator with an endotracheal intubation, the dental hygiene, unless we take extensive care about this, is likely to be contaminated. So it is very important that we take good care of the oral hygiene, especially in intubated patients. And the other is subglottic secretion. The gastric colonization can happen because most of these patients who are on ventilator have a high amount of stress, and this would predispose them to stress ulcers. So that's the reason why they are on some medications that reduce the pH. So this is like a double-edged sword. As we are trying to reduce the risk of gastrointestinal bleeding, we are also reducing or increasing the pH that will facilitate the growth of the organisms. So reduction in the gastric pH and enteral nutrition are other risk factors for gastric colonization. And also patients who are endotracheally intubated have a high risk for aspiration and reflux. Usually there is also a nasogastric tube along with the endotracheal tube. So the presence of this nasogastric tube will prevent the sphincters from closing. So there's going to be a high chances of reflux. And also there's a tube across the vocal cords and you're breaching the natural defenses of the and respiratory tract. So there is a chance of aspiration into the lower respiratory tract. And if the patient is supine, his chance of reflux and aspiration increases. So the factors that predispose to colonization of the airway from the oropharyngeal or gastrointestinal tract are one, the enteral nutrition. Again, there is a high chance of gastric distension when bolus feeds are given. And there is a loss of integrity of the esophageal sphincter, as I said, because of the nasogastric tube, so which increases the gastroesophageal reflux. And then the tracheal tube causes the vocal cords not to close, and especially if there is a PVC cuff. I suppose all of you have seen the endotracheal tube cuff, and when you inflate it within the trachea, it doesn't actually give you a complete seal. So there are some wrinkles around from which the gastric secretions can aspirate into the lower. And also sometimes there is an underinflation of the cuff, and this can again predispose to aspiration of the secretion. So when we are the other risk factor for patients on ventilator is when we are actually doing the endotracheal suctioning. Now, when we disconnect the circuit from the tube, what happens? There is no PEEP or positive pressure from within the lungs. So because of this zero PEEP and some pressure, what happens is the secretions that are around the tube or above the tube cuff are more likely to go into the lower respiratory tract. So during tracheal suctioning, because of the zero PEEP and the low positive pressure that's there inside the lung, there is a higher chance that these secretions that are pooled in the oropharyngeal cavity or above the cuff will trickle into the lungs. And also the patient-related factors like supine position, sedation, and viscous secretions and the larger tracheal diameter are all predisposing factors for having a reflux and aspiration. Now the other causes are like where it is difficult to do a pulmonary toilet. So then the secretions as well as the organisms pool in the lungs, and then that predisposes to development of pneumonia. Like any patient who's undergone a thoracic or an abdominal surgery, it is very difficult to give chest physiotherapy and make them cough out. Similarly, immobilization for whatever reason is another risk factor for that interferes with the giving of normal pulmonary toilet and predisposes to development of infections. So this is just a picture that summarizes whatever I've said. So there is a colonization and contamination of the oral cavity. and the natural defenses are impeded. So there is an aspiration of the microorganisms into the lungs, and you can have once the contamination, there can be an infection in the lungs. So to summarize, there is a micro aspiration. So once there is a micro aspiration, and there's also a biofilm formation along the endotracheal tube. So the secretions that are trickling down the tube can form a biofilm, and then because of the endotracheal tube, there is also an impairment of the mucociliary clearance. So these secretions or the organisms that are trickled down cannot be expelled because of the impaired mucociliary clearance. Now, what happens with this biofilm? If you look at this endotracheal tube, you can see that this is the cuffed endotracheal tube with the PVC cuff. So this is not actually aligning with the tracheal wall completely. So there is a small chance of leak around the tube. And also you can see that there's a sufficient space between the vocal cords and the cuff where the secretions can pool here. So this is a major cause of microaspiration and ventilator associated pneumonia. Now there is a formation of the biofilm along the endotracheal tube, and this again increases the chances of having an infection. Like you can see, there is an initial attachment of these organisms, and then they colonize and then they grow, causing the risk of ventilator associated pneumonias. Now, why is it important for us to understand this biofilm? Lot of us, how many of you put some saline or bicarb into the endotracheal tube when you do the suctioning? Non-ist hand lift, I do. Yeah. So when we put this saline into the endotracheal tube, what is happening? Now you're dislodging all this biofilm along with the organisms which can go into the lungs. So whatever's on the tube is now going to go into the lungs, and that increases the risk of infections. This is one of the things that we need to strictly avoid doing, because this can increase the chance of ventilator associated pneumonia. What are the common microorganisms that result in ventilator associated pneumonias? The common is, this again depends on from one hospital to another, but literature wise, these are the common organisms that are described. Pseudomonas, Staph aureus, the Enterobacteriaceae species like Klebsiella, Enterobacter and Serratia, Streptococcus, Haemophilus species, Acinetobacter, Neisseria, and coagulase negative Staph aureus. So these are the common organisms that are responsible for ventilator associated pneumonias. So now the most important thing, we've seen that there are a lot of preventable factors, both in the risk factors as well as in the pathogenesis of ventilator associated pneumonias. So what do we do to reduce this ventilator associated pneumonias? These are all simple interventions if we see, and very doable interventions. So first thing is, we've seen that the aspiration of these secretions are what causes the ventilator associated pneumonias. So reducing the aspiration of the oropharyngeal secretions is one of the most important tasks that we have to do. Next is modulation of this colonization, and also there are other things that are controversial, like use of antimicrobial prophylaxis and selective decontamination of the digestive tract, and also the practice of ventilator circuit changes. Now, as we said, the most difficult thing is to treat this ventilator associated pneumonia. And what increases the risk for this multi-drug resistant pathogenesis is any antibiotic usage within the 90 days, and hospitalization for more than 5 days, and high frequency antibiotic resistance in the hospital or in the community. And if the patient has some immunosuppressive drug or is on immunosuppressive therapy, then also the risk for multi-drug resistant organisms increases. And severe sepsis and renal replacement therapy are also risk factors for multi-drug resistant organisms. So we have to keep all these things in mind when we are choosing the antibiotic for treatment of this ventilator associated pneumonia. Now coming back to what we should do to reduce the VAP, or like the reason why we are all here is to understand how we can reduce, because reducing VAP is a multidisciplinary approach, and I'm very happy that there is a the nursing staff, which is the important pillar for intensive care, is also here. So no one person can actually prevent any infection in the hospital. It has to be a multidisciplinary care, and every one of us should be equally responsible for prevention of infections and management of infections in the hospital. So there is a very strong evidence that intensive education directed at this respiratory care that we do. So it includes the nursing staff, the respiratory therapist, and also the intensivists, plays a major role in reducing the incidence of VAP. So there has been almost as much as 50% reduction in the VAP, and some practices were introduced in the hospital and practiced. So that is the reason why we are all here. And the most important steps are, one, we are going to see each one of them in detail in the next couple of slides. The general measures that we take in the intensive care, and the other thing is to minimize the duration of mechanical ventilation. Obviously, if mechanical ventilation is predisposing to VAP, then if minimizing the duration of mechanical ventilation obviously would reduce the risk of VAP. And also to prevent the colonization of the respiratory tract by the organisms, minimizing the microaspiration, and also prevent the contamination of the equipment. And if you see, most of them are all doable things. So what the Institute of Healthcare Improvement has done is it has bundled up a few tasks. I think we have been hearing about infection control bundles in yesterday and today. So the VAP bundle has been created by this Institute of Healthcare Improvement, where they have actually bundled a couple of tasks together, because not one task is sufficient to prevent ventilator associated pneumonias. We need to actually use all these things together to reduce the incidence of VAP. So there are 5 most important things that we should do. Then there's no excuse for not doing these things to prevent the VAP. First thing is elevation of the head by 30 degrees. And this is such an easy thing to do. And obviously, if the patient is supine, the risk of aspiration is going to go up. So anytime, whenever you see a bed flat, the first thing that we should do is make it 30-degree elevation. Anyone, whoever is walking around, if you see a flat bed, just elevate the head end by 30 degrees. This is such a simple thing to do, but one of the most effective things to reduce VAP. And then daily sedation assessment and assess the readiness to wean. So by doing this, we can wean the patients quickly and reduce the duration of ventilation. The next thing is peptic ulcer disease prophylaxis, deep vein thrombosis prophylaxis, and also thorough daily oral care with subglottic suctioning. We're going to look at each one of them separately here. I'll come back to the summary slide in a while, or start with this. So basically what we need to do is, one, education and training for the airway management, strict hand hygiene. I think this has been reiterated in every infection control protocol, and it applies even to ventilator associated pneumonias, because this is one of the most contaminated and most with something that can be easily decontaminated by just simple maneuvers. And this can go a long way in preventing a lot of infections, including ventilator associated pneumonias. And then control and maintenance of cuff pressure, oral hygiene with chlorhexidine, semi-recumbent position, absolute avoidance of zero supine positioning, promoting procedures and protocols that safely avoid or reduce the duration of mechanical ventilation, avoidance of elective changes of ventilator circuits, humidifiers, and endotracheal tubes. The reason why we are talking about avoidance is, earlier it was considered that we change the tubes every 3 days and then change the humidifiers every. So by doing this, there are certain problems which we are going to see in the next couple of slides. So avoidance of these elective changes, that is changes without a obvious need for the change, is also not recommended. And there are some things that are controversial. One of them is selective decontamination of the digestive tract and continuous aspiration of the subglottic secretions, and then a short duration of antibiotics in all intubated patients to reduce the incidence of VAP. So these are some that are still controversial. So these are 7 mandatory basic measures that we should be doing every time. And then at the end of this slide, I'll again come back to this slide. So first thing we said was the general measures. Now these are some things that we routinely do in the ICU, but these also go a long way in reducing the PAP. So there are some things that are beyond our hands, like the host-related factors like age, lung disease, immunosuppression, or unconsciousness. But what we can do is the sedation, reducing the amount of sedation and reducing the period for which the patient is unconscious, and also avoid reintubation to the possible extent. And then there are certain device related measures that we can take, that is prevention of contamination of the endotracheal tube, ventilator circuit, and also the orogastric and nasogastric tube placement. And personal related, and this is something that we have to comply with, the hand washing. So whenever you see any non-compliance about these measures in the ICU, every one of us, I think, and we would like to empower the nurses to do so, because you are the ones who are constantly present in the ICU, and then you should feel empowered to implement these things. Even if you see the head of the institute or head of the department not following simple measures like hand hygiene when they enter the ICU, please feel empowered to tell them that you cannot enter my ICU or my ward without doing a hand wash. Only then the whole process gets rolling on. These are simple things that are very easy to implement, but then somehow there is a lot of change in the mindset that's required to implement these small, tiny things that can go a long way in infection control. So, first thing is washing hands. So, I think we've talked a lot, but I'm going to talk again on this, that use of these hand rubs, the alcohol based waterless hand rubs, before touching the equipment and also after touching the equipment. And whenever you come in contact with the respiratory secretions, it has to be done. So, before doing the suctioning and again after doing the suctioning, the hand wash has to be done. And the next thing is patient positioning. So, this position, as I said, was found to be one of the independent risk factors for developing ventilator associated pneumonia. And simple thing like 30 to 45 degrees head end elevation can prevent aspiration by nearly 34% and reduce ventilator associated pneumonias. So, the Center for Disease Control recommends that the head end of the bed should be elevated by 30 to 45 degrees unless it is contraindicated, like you have a patient with severe hypotension or you have a patient where the head should not be elevated. Every patient should have the head end of the bed elevated. So you can see here the effect of the head end of the bed elevation. So when supine, this is the risk of VAP, and when head end of the bed has been elevated, there is a significant reduction in the ventilator associated pneumonia. And the other thing that can help is turning the patient every 2 hours. So this not only helps in prevention of bed sores, but it also helps in improving the pulmonary drainage. So when you turn the patient from every 2 hours, there is going to be a pulmonary toilet that happens, and that can reduce the risk of ventilator associated pneumonia. And then the next task is daily sedation interruption and assess the readiness for weaning. So most of the time, these patients who are on ventilator are sedated so that the patient tolerates the ventilation well. But interrupting this sedation every day to see if the patient is ready for weaning or not. Because unless we reduce the sedation, it is difficult to assess for the readiness of weaning. Sometimes, like say, this simple thing, like even for 1 hour reduction in the sedation and assessing the patient, can actually expedite our decision to wean these patients. So by doing this, the duration for which the patient is on ventilator will come down. So things that increase the risk are continuous sedation, and then when you sedate with long acting drugs, again there's going to be accumulation of the sedation, and that will increase the duration of sedation, and also over sedation. So how do we prevent this over sedation? By assessing the patient's sedation with some scale. So this is again a small thing where you can just assess the patient's degree of sedation so that you don't over sedate the patient. So these small things can reduce the duration of mechanical ventilation, thereby reduce the ventilator associated pneumonia. So every patient should be awakened daily unless contraindicated, and then daily weaning assessment has to be done, and then at least like say Suppose today I have done for 1 hour, tomorrow I'll do it for 1 hour 15 minutes. So every day increase the duration for which the sedation is weaned off, so that the patient can be weaned off the ventilator quickly. So the next most important task, though it looks very simple and small, but it has a highest effect on the ventilator associated pneumonias, and that is oral hygiene. So whenever the patient is on mechanical ventilation, obviously the plaque formation increases because there is no salivation and the patient is unable to clear his. So because of this absence of mechanical chewing and saliva collection, there is increased dental plaque formation. So this tooth brushing, now there are a lot of commercially available brushes available, but if not, even a simple finger with a gauze that normally all of us do can help in clearing of this plaque and reducing the amount of secretion plaque on the tooth. And then the other is use of this chlorhexidine oral rinse. So just rinse it with the chlorhexidine and that will reduce the contamination and improve the oral hygiene significantly. And this can have a significant effect on reduction of the ventilator associated pneumonias. The other thing that is controversial is the selective decontamination of the digestive tract. So a lot of regimens have been suggested for selective decontamination because we presume that the oral and the gastric secretions are the cause for this ventilator associated pneumonias. It was considered that if we decontaminate these areas, we will be able to reduce the incidence of ventilator associated pneumonias. But then obviously we've been listening in the last couple of days, like what happens if you give antibiotic regimens to decontaminate the oral cavity? You're going to facilitate the growth of multi-drug resistant organisms. So this is like a double-edged sword. By trying to reduce the amount of organisms, in the long run, you are facilitating the growth of multi-drug resistant organisms. So this again has been given up. So we don't really follow this practice unless in high-risk patients. So there are various regimens that have been described, like 2% gentamicin with colistin with vancomycin paste applied QID, or some people have even added an antifungal into this oral paste to decontaminate the oral cavity. But again, as I said, all this will promote growth of resistant organisms and should not be routinely done. So what should we do? First is daily assessment of the oral health. Probably, as an intensivist, I'm very, I examine this, that cardiovascular system, respiratory system is on top of my mind. But oral hygiene is something that I hardly bother to go closer and check whether the oral hygiene is good or not. But this is one practice that can actually help in reducing the amount of infection. And once the patient develops a VAP, after having carefully manage these patients for all high risk diseases, if the patient develops VAP, I think the whole thing goes to the drain because it's very difficult to treat and a lot of mortality once the patient develops VAP. And then just simple tasks like oral hygiene can go a long way in prevention. So brush every 12 hours and then routine suctioning of the mouth along with the oral secretions to prevent aspiration, and use of alcohol-free antiseptic oral rinse to reduce the bacterial load of the oropharynx. The next thing is that is again a little like a double-edged sword is use of drugs that increase the gastric pH. Now, how do they help and how do they damage? One, the reason why they are given is basically to increase the pH so that the risk of bleeding comes down. But then you are also increasing the chances of colonization with this. But the reason why they can help is by reducing the reflux. So these drugs also have an effect on increasing the motility. So they reduce the reflux, but at the same time, they can also increase the organism. So they need to be used, but you have to be cautious when you're using these drugs. Now, what are the recommendations for the airway management? First thing is like that endotracheal tube is the one that is risking to VAP. So if we can avoid use of endotracheal tube by use of non-invasive measures to mechanically support these patients, that can be useful. And also whenever possible, minimize the duration of mechanical ventilation. And then earlier it was considered that the nasotracheal intubation probably is better than orotracheal intubation because you are avoiding the oral hygiene can be better. But then it was seen that the risk of sinusitis is higher when nasotracheal intubations are done, so we don't do that. And now early tracheostomy is one thing that is again like pro and co. No, but a lot of studies have shown that use of early tracheostomy can minimize the ventilator associated pneumonia. The other thing that we can do as intensivists is avoidance of reintubation. So, diligent timing for extubation where we can avoid reintubation because reintubation is one of the risk factors for development of ventilator associated pneumonias. So, any patient who is reintubated, the risk of VAP goes up by nearly 5 to 6%. And the next thing that we often neglect is the cuff pressures. How many of you in the intensive care check the cuff pressures regularly? That's good. So, maintaining the cuff pressure at 25 to 30 is something that can help in minimizing the leak along the cuff and reduce the ventilator associated pneumonias. So again, like how do we do the suctioning? That's one of the probably the routes by which the organisms gain access to the lower respiratory tract and increase the risk of VAP. So I have already discussed about this use of normal saline. So this has to be avoided. Routine use of normal saline should not be done because it can dislodge the organisms and so that they gain access to the lower respiratory tract. And then what do we do with this suction catheter that we have in our hand? So there is always a practice that you reuse the suction catheter sometimes. So this should be avoided. And whenever you are, if we have to reuse, this should be kept in a dry, sterile bottle. So there, I don't know, even we had that practice of keeping the suction catheters in saline after use. I think that has to be abandoned. So how can we avoid the use of normal saline? So obviously, if we avoid the need for using this normal saline, then why do we use normal saline? To loosen up these secretions. So that is because the secretions are getting dried. So if you can prevent these secretions from getting dried up in the airway, then you can avoid the use of normal saline, obviously. So adequate hydration, humidification, and nebulization with mucolytics can minimize this drying up the secretions and thereby minimize the need to use some saline or something into the air. The other tubes that have come up in the recent past is the suction above the cuff tubes. Now, how many of you have access to these tubes? Okay, what this tube has is, in addition to the regular cuff, there is another hole or another tube that goes and opens here above the cuff. So any secretions, if you can see, the cuff only prevents the secretions from going below the cuff. But what about above the cuff? There's a lot of space here between the cords and the cuff where the secretions can come and collect. So what these company has done is they have provided a opening here from which the suctioning can be done. So all the secretions that are pooled between the cuff and the vocal cords can be suctioned by use of this suction above the cuff tubes. So the oral cavity you're going to suction with the end suction tube, but below the cords you cannot suction with the suction tube. So below the vocal cords and above the cuff, there's an opening from which the suctioning can be done. So some studies have looked at whether continuous suction of this secretions can help in reducing VAP. Again, there is no consistent evidence that doing a continuous suction can help, but still intermittent suctioning can be useful. So continuous suction can be used. It's not like it should not be used, but the benefit over intermittent suctioning has not been demonstrated. So for any patient who is expected to have the endotracheal tube for a longer period, it is preferable to use these tubes instead of the regular endotracheal tube. And again, like earlier we had a practice of changing these ventilator tubings every 2 to 3 days. Now, why should this frequent changing be avoided? For an administrators, if there are any here, they'll be very happy if I say I don't want to change the circuit because that saves a lot of money for them. But then more than saving money, it is about saving the patient. See, whenever we change, we are going to dislodge some secretions from the circuit into the endotracheal tube and thereby into the lower respiratory tract. So anything that wherever we are meddling with this circuit, we are going to dislodge these secretions from the tubings. So obviously, there's going to be some collection of the condensed water along these circuits, which is again a rich source for the growth of these organisms. So first thing is that how do we reduce the need for changes of these ventilator tubings? So if we can prevent these water from condensing into the tubings, you can avoid the need for the change. Now, how do we prevent this water from condensing in the tubing? Yeah. So by heating the expiratory tube, you can prevent the condensation there. So because you see the moisture that comes out, the expired air has more moisture. So once it comes into the tubing, it's going to collect there. So if we heat the expiratory limb of the ventilatory circuit, that can prevent the condensation of this moisture in the expiratory limb. And also, like, we don't need to really change unless the tubing is soiled. So next, at the end of the case, or even between the cases, the ventilator has to be disinfected and kept sterile. I think this is one place where if you don't really take care, clean it every day, that's the place where a lot of dust collects or infection. And sometimes we keep touching that's the most high touch area is the ventilator knobs. So all these things have to be decontaminated on a regular basis. And whenever the patient is on oxygen mask again, even so that is not free of infection, because there can be a lot of secretions pooled in the mask which can cause infection. Now, the way we do this suctioning is again very important. As I said, hand washing before and after the procedure, wear clean sterile gloves to prevent cross contamination, use a single use suction catheter, and if it's not possible, rinse it with sterile water and keep it in a dry bottle. And this has to be changed at least 8 to 12 hours, even if we are reusing it. Then the suction bottle. So this is again a major source of infection. Nowadays, we have these disposable single-use suction bottles. I know that all of us belong to institutes which cannot afford these disposable bottles, so we use the reusable suction bottles. So these have to be washed and allowed to dry, or if possible, heat disinfect these things, send it to the CSD for whenever it is possible. So if we have two sets, maybe we can keep sterilizing one and changing it every 20. Then the other source of infection is these humidifiers. Again, clean and sterilize these devices between the thing, and the mechanism by which you can prevent the infection or growth of the organisms in this humidifier is heating this humidifier and changing the water every 24 hours. The next step in preventing VAP is how we feed these patients. So we were talking about gastric pH and organisms. So early enteral feeding can decrease the bacterial colonization and can prevent the ventilator-associated pneumonias. Then when we talk about enteral feeding, we also have to understand that when bolus feeds are given, there's going to be some gastric distension, which is going to increase the risk of aspiration. So prevent large boluses. I think there are some studies that have looked at continuous feed versus bolus feeds. But most of them have not shown any major difference. But then, if possible, continuous feeds can be helpful because bolus feeds can increase the risk of aspiration. And then elevate the head end of the bed whenever the feed is given and verify the tube position before every feed. So, some studies have looked at whether small bore catheters are better than large bore because of the sphincter closure can be better there, but then there is no studies have not shown any difference. Again, there is controversy about continuous feeding and intermittent feeding. Literature doesn't show any superiority of one over the other. The other thing that has been in practice is post pyloric feeding. That is the nasogastric tube. Instead of nasogastric, we place a nasojejunal tube. That is, the tube goes beyond the pylorus into the jejunum. The advantage of this obviously is that the gastric stasis is lesser, so the risk of aspiration becomes lesser. Again, no study has really shown superiority of this over having a nasogastric feed, but still it can help in prevention of ventilator associated. So what will help us in this is about the bundles. Now, what will help us in seeing whether we are doing enough for the patient in preventing this VAP or not is to have a small checklist or a complaint sheet. So you can have the date here and then tick whether it is yes or no. So all the bundles that are described can be on the sheet, and then we can just keep ticking yes or no every day. Like, this is the sheet that looks at head end of the bed elevation, sedation, readiness for weaning, oral care, hand hygiene performed during suctioning or not, whether sterile water is used whenever we are reusing the equipment. I think most of the time saline is something that is very handily available. So we use that instead of sterile water. So we need to have some changes in the practice to reduce the VAP. And then ventilatory circuit is changed only when it is required. So when a small checklist can actually help us, we all feel that we are very great and have great memory and we can do away with without the checklist. But then still we are still humans, so it's not possible to check this adherence every day. So for the nurses, just have a checklist in your hand and see whether each patient has all these things are done or not. So just a small checklist will help us in looking at the compliance. I think unless we achieve 100% compliance without being bothered, that is when we can probably do away with the checklist. But until that point, I think you have to chase everyone in your intensive care to make sure that these practices are in place. So the other preventive practices are controversial are the antibiotic containing preventive strategies. So as we have been talking about, when you are using these antibiotic containing practices, it helps in prevention of the infection, but it also increases the growth of resistant organisms. So there's a lot of controversy that surrounds these things, and probably these days these are not practiced. So now, why is it important for us to look at this prevention so diligently? One is the high incidence of VAP in patients who are intubated, and then the high incidence of mortality in patients who develop VAP. So that is the reason why we have to be very diligent in looking at all the preventive strategies. So sometimes, like, despite all these preventive measures, we still need to be vigilant for the development of VAP. So we can still have VAP despite all these things. So we need to look out for VAP or not. Now, how do we see that? There are clinical criteria, radiographic criteria, and the diagnostic criteria. So the clinical criteria are development of a new fever or development of new purulent secretions, leukocytosis, or worsening of the respiratory parameters, and some Krebs or diseases on the auscultation. So these should give us a clinical suspicion of whether there is a ventilator-associated pneumonia. Radiologically, obviously, any new patch in the X-ray should lead us to a suspicion that it could be a ventilator-associated pneumonia. So even in the absence of the patch on the X-ray, you can still have VAP, and that is because when you can have a tracheobronchitis without having pneumonia, and that is still ventilator-associated respiratory infection. So the helix criteria for diagnosing VAP are radiographic evidence on 2 serial chest X-rays of a new or a persistent lesion, and then presence of one of these followings: fever or leukocytosis, and 2 of the other criteria like purulent sputum, auscultation findings, tachypnea, or worsening of the gas exchange. So these are the criteria that we use to diagnose ventilator-associated pneumonia. Now, there are a lot of other conditions in the ICU that can cause these changes, and those are things like pulmonary infarction or embolism, development of pulmonary edema, pulmonary contusion, chemical pneumonitis, or some drug reactions. So there is a clinical pulmonary infection score based on 6 variables, and those are temperature. Each one is scored like this. I'll not read out the thing. This is always available, so you can look at this. So the CPIS can tell us about the diagnosis of ventilator associated pneumonia. So a score of more than 6 is considered diagnostic of ventilator associated pneumonias. So this score is based on temperature, the leukocyte count, the tracheal secretions, the radiographic findings, the culture results, and the oxygen status. So the microbiological evidence comes from either the blood cultures or the tracheobronchial secretion cultures. So we have to send 2 sets of blood cultures whenever we suspect an infection. And if there is a pleural effusion or something, we can send one set from this thoracocentesis and one set from the endobronchial aspirate. Now, there are different ways of collecting this endobronchial aspirate. What do all of us do? We do a suction and send the tip for culture, isn't it? Or send the secretions for culture. So there are other ways of doing it also. One is send a clean sample. So send it in a sterile container. So it has to be a silicone coated glass or a polypropylene container in which the suction catheter at the tip is sent or the fluid is sent, and then it should be transported to the laboratory within 2 to 3 hours. And if there is a delay, then it should be kept in a medium, and don't send it beyond 24 hours because you'll have contamination there. The best way to send these tracheobronchial secretions for culture is to do a bronchoalveolar lavage and send that sample, because when we do a suction into the endotracheal tube and send it, you are also sending the organisms from the biofilm that are adhered to the endotracheal tube that will invariably come along with your endotracheal suction catheter when you're doing this. So best way is to do a protected breast specimen through a bronchial fiber optic and send it. So there is less contamination when we do it there. So you can target the antibiotic therapy carefully when you do this. A lot of times we get reports like Acinetobacter, possible contamination. We don't know whether that is responsible for the pneumonia or it's just a contamination that we are getting. So if we send this protected breast sample from a bronchoalveolar lavage, it is more accurate and we can believe that specimen and direct our treatment of the antibiotics according to that. But then whenever you want to do a bronchoalveolar lavage and send a sample, it can be most probably easier done in a patient who is intubated. If it's not, then we need some sedation for this. And the PEEP also has to be adjusted according to that. Because whenever you do a bronchoscopy, the patient is dependent on PEEP. And when we disconnect it to do this bronchoscopy, obviously it's a procedure that takes a longer time. So the patient is going to be off this PEEP. So all the benefit that you have achieved by recruiting the lung with the PEEP is also going to be lost when we are doing this for a long. So this has to be kept in mind whenever we are doing a bronchoscopy. See, the other way is the non-bronchoscopic techniques, as we routinely do the tracheobronchial aspirate. So here the endotracheal, the catheter is passed blindly. So for the criteria for diagnosing VAP with this mini ball is CFU of more than 10 to the power of 5 per ml. So if you're doing a bronchoalveolar lavage, then it is 10 to the power of 3. So now if we compare the bronchoscopic versus blind techniques, obviously the bronchoscopic technique has a better yield than the blind techniques. But however, if you look at the literature, there is no major difference between a ball sample and a properly done endobronchial suctioning and sample. Now, once we diagnose VAP, how do we treat it? So we have sent the sample for culture, diagnosed it, and sent the sample for culture. So always change the antibiotic after you have sent the cultures. So if you have an initial inadequate antibiotic therapy for VAP, the outcomes are worse. So do not delay the antibiotic therapy until you get the report. You can start the antibiotic therapy. So again, as I said, the onset of the VAP will help you choose your antibiotic. If the onset is less than 5 days, it is less likely that it is a multi-drug resistant organism. If the onset is more than 5 days, it is more likely that it is a multi-drug resistant organism. And also in immunocompromised patients, it's more likely that it is multi-drug resistant. We choose the antibiotic accordingly. So for early onset with no risk factors, the possible microorganisms are the Enterobacter species like Klebsiella, Proteus, E. coli, and also Staph aureus or Streptococcus. So the antibiotic regimen should contain a third generation cephalosporin or a fluoroquinolone or a beta-lactamase inhibitor or a carbapenem. So these are the antibiotic choices for an early onset pneumonia in a low risk patient. If the patient has high risk like immunocompromised, or a late onset where the organism is likely to be multi-drug resistant like Pseudomonas or Acinetobacter, then we start them on anti-pseudomonal cephalosporins or anti-pseudomonal carbapenems. And like regimens like this can help, like have a anti-pseudomonal fluoroquinolone along with an aminoglycoside plus vancomycin or linezolid. So initial antibiotic therapy that is directed at the likely organisms is more likely to reduce the risk of mortality than having an inadequate antibiotic therapy. So these are some of the suggested regimens for patients with no risk factors for multi-drug resistant organisms: ceftriaxone or moxifloxacin or ciprofloxacin or ertapenem. Patients with risk factors for multi-drug resistant pathogens, we can choose ceftazidime or piperacillin tazobactam or gentamicin or etobromycin with ciproflox or levoflox, or a combination of linezolid and or a vancomycin. Now, once we start this antibiotic therapy, you need to assess whether there is a clinical improvement or not. If there is a clinical improvement, but the culture is negative, we can stop the antibiotic. If there is a clinical improvement, but the culture is still positive, you can reassess and de-escalate the antibiotic. But if there is no clinical improvement and the cultures are negative, look at the other causes or you may have to repeat the cultures. But if there is no clinical improvement and if the culture is positive, then reassess the antibiotic sensitivity and give the antibiotics for a longer period of time. Now, why are we so concerned about ventilatory associated pneumonias? One is because I said, because of the increased mortality and morbidity, and it also increases the length of stay of the hospital. So as the length of stay increases, the cost also increases. And the incidence is like as high as 10 to 65%. And again, remember, most of the things are preventable and the mortality is 27%. So again, remember that though the mortality of VAP is supposed to be around 75%, not all deaths are because of VAP alone. So you also have to look at other causes for infection along with the VAP whenever you have a patient who is deteriorating. So main, early diagnosis and aggressive therapy. These are the two things to reduce the mortality. So early diagnosis requires high clinical suspicion. So do an X-ray, a bedside clinical examination, and also send the cultures. So along with the antibiotics, just simple nursing and respiratory therapy measures can also go a long way in reducing the severity of the infection. So coming to the conclusion of this talk, there are certain, I'll just summarize whatever I have spoken so far. So one, ventilator associated pneumonias is important because it's a significant cause of mortality and morbidity. Excuse me. So the key factor for development of VAP is the cuffed endotracheal tube or tracheostomy. So see that you minimize the use of these two and also minimize the duration for which these are used. So any patient who is undergoing mechanical ventilation for more than 48 hours use a suction above tube, endotracheal tube. And if it's an early and onset VAP, then you can choose antibiotic that sensitive to community acquired pneumonia. If it is a late onset, we have to remember that it is multi-drug resistant and choose the antibiotic accordingly. So simple things like measures to reduce the VAP, like early weaning protocols, disinfection, and hand washing can go a long way in prevention of. So it's mostly a multidisciplinary care that helps us prevent this VAP. So all of us are key pillars in prevention of this, and just simple measures can go a long way. So just make sure that as nurses, as physicians, we effectively implement this VAP bundle. VAP bundle is nothing but just 5 simple measures which can be easily implemented in the ICU, and this can go a long way in prevention of VAP. Thank you. If there are any clarifications, I would be happy to answer them. Pardon? Yeah. PEEP actually, like, it prevents the risk of aspiration. Because of the positive pressure, the chances of these secretions trickling down are lesser when we use it. To at least the minimal PEEP that we use on ventilator, like 5 centimeters, will help. So the only problem is when we disconnect for suctioning. So that is where the closed suction catheters are likely to be helpful in prevention of VAP as opposed to disconnecting the circuit and doing the suction. Puff pressure, how often? I think that are no definite guidelines, but at least twice a day should be enough for us to see whether you're, yeah. Twice a day should be.
And putting closed suction drainage kit is available.
Yeah.
It's better if you use suction drainage to prevent VAP.
Right. Closed suction drainage is very useful in prevention of VAP. And as I said, like, it also helps us maintain the ventilatory parameters, and that's how the deterioration of the patient during suctioning can also be minimized with.
Tracheostomy, promote early tracheostomy.
Yeah. I would like to hear more from the nurses. Any practice changes that you would want to do in your ICUs? Just tell me, what are the existing practices that you have right now which are likely to result in prevention? A little louder, please. Yeah, any one of you, just tell me. What are the current practices that you're following to prevent VAP? Yeah.
Hygiene. Preach in the hand hygiene, because every second hourly uh, doing to all the children who are all ventilators, that is quite impossible sometimes. Hand hygiene is fine, but wearing PPE all the time. And the other one is using saline during the suctioning. So what do you suggest, ma'am? Is it go with saline or distilled water, or sometimes even soda bicarbonate also. Like if thick secretions are there, we are even going for soda bicarbonate as per doctor's order.
Yeah, I'll start with hand hygiene. Yes, like even if you don't wash your hands with water, even the hand rub that we do properly done with an antiseptic solution will really help. So I think chlorhexidine is readily available at each bed most of the time. I hope so. That will also help a lot. I mean, that's one of the easiest and most effective steps to reduce VAP. We don't need PPEs for endotracheal suctioning. What we need is sterile pair of gloves. But what happens is I wear a sterile pair of gloves, but then most of the time I do understand that we are alone. So you hold the saline bottle with that, you hold another thing with that, you peel off the suction catheter with the same hand. A lot of sterility breach is there even if I'm wearing. So probably you what you can do is, I mean, if possible, wear a double glove so that you can take off the top one after you do all those things and then do the sterile suctioning with the next pair of gloves. I'm sure if there is an administrator here, he will kill me for asking you to wear double gloves. But then it's a simple measure. See, I mean, instead of spending 5,000 rupees on an antibiotic, you're spending 10 rupees on a glove. Simple measure of wearing a double glove and then taking it off and then doing the actual suctioning with the sterile pair of glove will help us. So that is one thing. And next thing you asked me was about instilling these things.
Normal saline
I
or
think
Destio?
best thing is to avoid instill anything into the endotracheal tube. As I told you, your imagine like say there is a invariably there's going to be a biofilm formation on the endotracheal tube. So there is like whenever we remove the endotracheal tube, you would have seen that there is a column, there is all along the tube, especially at the tip, there are a lot of secretions and then there's a lot of film there. So this film is one of the most contaminated thing. Maybe that's not infection still, but it is contaminated. So when you put this saline or whatever into the endotracheal tube, you are going to dislodge the whole thing into the lower parenchyma. So that is when the ventilator associated pneumonia happens. So this is a practice that we should never do. But if you're looking at babies, as you, I think you must be practicing in neonates. So it's a very small tube and probably very easily blocked, especially if you don't have a humidifier along with it. So that is when probably the measures that we do to reduce these thickness of the secretions will help us in minimizing the use of this saline.
I have some set of questions with me. I am not sure whether this is the right time to ask. Spill management is not covered in the topic, ma'am, because we wanted to know the biological spill management, mercury as well chemicals. Because protocols are varied from one organization to the other organization. And I have another question like, what are the cleaning biological and chemical, and we just wanted to know the differentiation of mercury spill. How do we, what is the protocol, and chemicals in case of spill, minor spill and major spill management. And the other one, ma'am, cleaning machines. What are the cleaning various machines are used in NIMS, like jet machines or scrub machines, and what are the cleaning disinfectants are used here for various things like glass cleaning and wall cleaning, and some of the points were covered by sir. And still we want to know the frequency of water tank cleaning and mortuary cleaning and certain things also, ma'am, which was like not covered in the slide. Thank you, ma'am.
Thank you.
Thank you, madam, for your enlightening lecture. And next, I invite Dr. Radhika. She's from Clinical Pharmacology and Therapeutics. Radhika will now give her lecture on rational use of antibiotics. She is very much interested into antimicrobial stewardship program. So today she will have a kind of interactive session also with you. Thank you.
Good afternoon to all of you. A very good afternoon to all of you. I thank the organizers for giving me this opportunity to interact with you. Actually, today the topic which I am going to speak is a very important topic, which is role of nurses in ensuring rational use of antimicrobials. In this, I have mainly said nurses because doctors have to also insist nurses to practice these things, because just prescribing a medication is not it. It has how rational use of in the rational use of antimicrobials a nurse can play a prominent role, and how a prescriber, a clinician, should insist the nurse to adopt these practices in an intensive care unit or an inpatient setting or at a microbiology lab. Without wasting much time, I'll just get into the topic proper. In this, I would talk about the basics. Then I will go to the prominent role of nurses in rational use of antimicrobials. Then I'll speak a little about the antimicrobial resistance and why we are emphasizing this role of nurses here. So this will be an interactive session because most of the things you are practicing. I just want to know how much are you aware, and how much we need to implement and increase our awareness towards these topics. Please give the mic to anybody, okay, who wants to answer this question. Which of the following is not a microorganism? SARS-CoV-2, Candida albicans, Plasmodium vivax, pinworm, and Klebsiella pneumoniae. Anyone? Pinworm. Yeah. Can one of you tell me why pinworm is not a microorganism? It's visible. It's visible to the naked eye. Correct. So how do we define a microorganism? Is a microorganism or microbe is an organism of microscopic size, which can be seen only through a microscope. So these microorganisms generally include four things: bacteria, viruses, certain parasites like plasmodium or amoeba. Though they are parasites, they can be microorganisms because you can see them only through a microscope. They are not visible to the naked eye. And fungi. So this is a microorganism. So we are going to target our class today on this particular microorganisms. Which of the following is not an antimicrobial agent among this? Amoxicillin, acyclovir, doxycycline, phenytoin, and isoniazid. Phenytoin. It's a anticonvulsant, right? Amoxicillin is generally used for gram-positive and gram-negative bacterial infections, some of them. Acyclovir is a antiviral, very nice. Doxy is a tetracycline, which is again for a broad spectrum of microorganisms. Phenytoin, as you have all said, that it is an anticonvulsant and does not fall into this category. Isoniazid is mainly antimycobacterial. So we use it in the treatment of tuberculosis. Now, how can we define an antimicrobial agent? Anyone who wants to define what is an antimicrobial agent? Mic iva.
Agent is microbial action and growth and
It kills it. Correct. So, antimicrobial agent is any agent or substance that kills or inhibits the growth of microorganisms. Very correctly answered. So, any agent which is used to kill or inhibit the growth of microorganisms falls into this place. Now, I would like to ask you to share your experience with regard to changing trend in prescription of different classes of antimicrobials at ICUs or wards in the last 10 years. 10 years back, what was the most common antimicrobial which was prescribed for gram-positive or gram-negative infections? For gram-positive, what was the commonly used antimicrobial, from your memory, if you can tell me, 10 years back? Ampicillin. Ampicillin? Ivandama. Cloxacillin, ampicillin, right. Now, after 10 years, what is the most commonly prescribed drug for gram positive or negative? Vancomycin we are using instead of cloxacillin. This has come into our setups. We are using it regularly. And for gram negative, I can hear meropenem somewhere. And what other drugs? Colistin, yes. We are using colistin also now very frequently. Then piperacillin and tazobactam I can hear. So these are the drugs which are being prescribed. The change is from cloxacillin to, we are also looking at vancomycin in lot of cases which we are giving treatment to. And then we have seen ampicillin or amoxicillin has been replaced by the broad spectrum antibiotics like piperacillin or meropenem or colistin also in some places. So why do you think these classes of those classes of antimicrobials are not prescribed today, like amoxicillin as an empiric antimicrobial therapy? Before you know what is the organism which could have caused the infection, we are starting with a piperacillin or a meropenem, right? Why do you think that we are not prescribing amoxicillin now? Because most of the organisms are showing resistance to the amoxicillin. That's why doctors are not in favor of prescribing a amoxicillin now. They start with the empiric broad spectrum antibiotic like piperacillin, tazobactam or piperacillin or meropenem, isn't it? So antimicrobial, the resistance of microorganisms to these drugs, narrow spectrum antimicrobials, which we call ampicillin or penicillin or gentamicin or cloxacillin, has increased. The rates have increased, so we don't want to take the risk. The doctors don't want to take the risk, so they are going with a broad spectrum antibiotic management. So we have discussed this already. What is your observation in the susceptibility of microorganisms? We come to know that the resistance has increased to some of the narrow spectrum antimicrobials. Why do you think these susceptibility patterns have changed? Improvement of the insufficient doses of antibiotics is one answer. More answers I want, because there are many causes, you know. VOX, RMPs, yeah. Empiric antibiotic, broad spectrum antibiotic prescription for common infections at the community level also by registered RMP practice, isn't it? They are giving so many broad spectrum antimicrobials without having adequate knowledge of what should be the antimicrobial that can be prescribed by them at for that particular infection. Without sufficient knowledge, they are also prescribing. What other things? Inadequate use by the patients. Very correct, sir. After 24 hours or 48 hours, when they get the response, the 70% reduction in symptoms, most of them tend to stop the antibiotic therapy. The causes may be many. It could be compliance, it could be money, it could be anything. What are the other causes which we can think of? Over-the-counter sale, I can hear here. Yes, over-the-counter sale, the consumers don't go to the doctor itself. They go to the pharmacist directly and try to procure the antibiotics even without a prescription of physician, maybe based on their prior experience or from the neighboring people can suggest them that when I got such an infection last time I went to a doctor, he gave me this prescription, you try this. And we have that over-the-counter sale in India still. So this is also because it was not adequately assessed what condition the patient is having and what antibiotic was appropriate for the patient. More income. More income how, sir? Can you explain? Google is a very interesting subject, you know. Yes, again, taking appointment from clinicians, sitting in the waiting areas is tedious. First initial thing is a Google guru is there. So you ask the Google guru and over-the-counter sale is there. You can prescribe yourself. Self-prescription can be done. So that is one area where broad-spectrum antibiotic use is getting mismanaged, is getting rampant, I should say. clinician does not want to take chance, fear of clinical failure. So let me give the best shot so that the patient will be happy within 48 hours. Patient also wants the same result, doctor also wants the same result, and there are weapons here, broad spectrum antibiotic. Without knowing the isolate, without making an effort to know the isolate itself, we can prescribe a broad spectrum antibiotic and get whatever result we want. This is the kind of thinking which is going on. So these are the reasons for which susceptibility patterns have changed. And can we stop this development of resistance in microorganisms? By any way, for sure. Can we stop? Yes. What are the measures? We will see throughout. But for me, I just wanted to tell you that this resistance, development of resistance in the microorganisms is a inherent survival mechanism for the bacteria, isn't it? The microorganisms are also living organisms. Every living organism wants to live, isn't it? It wants to live, it wants to increase its progeny. The reproduction should continue, its genre should be there, its species should be well established. Every living organism, inherent thinking is, inherent natural mechanism, tendency is this, isn't it? No microorganisms wants to completely close its lineage. So bacteria, these microorganisms are very, very notorious in changing their genetic patterns itself, developing mutations so that the antibiotics will not act on them. So they are developing very good survival mechanisms, changing their mutations, changing their genetic structure, and trying to live despite the presence of antimicrobial agent. That is nothing but resistance. So this is an inherent tendency of a microorganism. There is no, I cannot say 100% that if we do all these things, then the resistance can be stopped, because it will develop some other mechanism. But what we can do is we can minimize keep this resistance pattern developing to the minimum. We can minimize the resistance development of resistance in these isolates by making our efforts in different ways. In one of those ways is rational use of antibiotics. So let us see, go on to the next. So what happens if this antimicrobial resistance increases? What is the impact of this AMR trend, which you are already seeing in your hospitals, in your ICUs and wards? What's happening when, how would the patients respond when 10 years back and today, when you are dealing with a resistant microorganism, how are the trends? When you are dealing with a susceptible microorganism, how was the trend? Can you just explain, share your experience? Oh, increased hospital stay is happening because of resistant isolates, because it is not easy to treat the infections safely. Then response to the treatment is very poor. The duration of hospital stay is increasing. Because duration of hospital stay is increasing, what happens? Cost is one thing. Hospital acquired infection, second infection chance becomes more. So when the patient tends to stay a lot of time in the hospital, again, second infection chance also increases. So hospital acquired infection chance also increases. And on the morbidity and mortality, morbidity increases because it is proportional to the duration of hospital stay. And outcome is dependent on whether the treatment will be effective or not. The mortality rates are how much we will discuss. So now while treating such isolates, we are seeing all these things. The increased duration of hospitalization, combination therapy is increasing so much, we are not very sure whether one drug will be helpful, effective in treating the organism, because we don't know whether it's a gram positive or a gram negative or a viral or a fungal, because all these organisms for a respiratory tract lower respiratory tract infection will present with the same symptomatology, isn't it? The same symptoms of cough, breathlessness, the crepitations, everything will be the same. Unless the blood investigation is done and further biomarkers are done, we are not very sure based on the symptomatology whether it is a bacteria or a virus or a fungus or a parasite. So what we are doing as empiric therapy is we are not just giving a meropenem. We are adding a vancomycin, because what if it is a gram positive, methicillin resistant, I am adding a vancomycin. I am not sure whether it is bacteria. I am adding a fluconazole or oriconazole because it could be candida based on other factors, patient factors. So I am going on increasing the number of drugs at the time of empiric antibiotic prescription, isn't it? So during the treatment, not just increasing the duration of hospitalization, but we are adding more antibiotics, which will increase, which will affect the safety also of the patient. More antibiotics, more adverse events. Again, you have to deal with the adverse events as well. For them, again, you have to prescribe many medications. So the number of drugs a patient takes is going more than 5 or 7 once a patient gets an infection these days. If 10 years back, it was only 3 or 4 drugs. But now we are going up to 7 to 10 drugs in each patient, isn't it? So this is one area where there is impact. This is the impact which we are seeing on day-to-day basis in our own wards, isn't it? In our clinical settings. So how nurses can help in rational use of antimicrobial agents? Let us see this. First, I want to know, I want to understand in how many, in all those nurses who have come here from different setups, in how many setups do you have culture susceptibility support from the microbiology lab? 1. Any more places where they are doing a culture susceptibility? 1, 2, 3, 4, 5, 6, 7, 8. So there are good number of setups in which the culture susceptibility tests are being done and the microbiology lab is supporting it. However, there are many hospitals where even culture susceptibility tests are not done. So there the impetus is more great. I mean, there the kind of treatment which is given is completely blinded. They don't know what they are dealing with. Actually, they are fighting with an organism which is unknown to them. So it is a very gray area there. But at least in those setups where the culture sensitivity test is done, how are we utilizing this culture sensitivity test? I want to know a little about this by interaction. So what happens at the laboratory after a culture is sent to report culture susceptibility? Any idea? Yes? So already the patient will be on antibiotic. The culture will be sent when? Stopping the antibiotic. Actually, ideally, we have to send the culture sample for culture susceptibility test before starting the empiric therapy. But what's happening? Are we sending it like that? No, most of the times it's getting delayed. The empiric antibiotic therapy is going before and later the cultures are sent to the laboratory, isn't it? So whatever it is, once the culture sample is collected at the ward or ICU, how fast are you able to send this to the laboratory is my first question. From the ward, it should go to the laboratory. Sufficient quantity of sample should be sent. This is very important. Otherwise, if you say send inadequate sample, it will not be useful for anything. The microbiologist will always say inadequate sample sent, again redo the culture, isn't it? So you have to send the right amount of sample to the laboratory in a right container. That is also very important. And once you collect the sample at the ICU or ward, what is the average time in which this sample is getting transported to the laboratory? It immediately happens? Very nice. In every setup it is happening immediately? No. How much time on an average it takes? Half an hour. Okay. It is half an hour after taking the culture. Half an hour to 1 hour. Correct? And after it reaches the microbiology lab, what do they do? Any idea? Any idea of how this culture sample is processed? They will actually, how they will capture how they will give you a report that this particular Klebsiella is there in this particular secretion. What is the process? How laborious or how tedious, how labor intensive is that process? Any idea? Actually, in the microbiology lab, they have to make this culture plates. Okay, the culture plates, to make the culture plates itself is a very tedious thing because they have to be made in a sterile condition. Okay, large number of plates are kept ready by the microbiology technicians to culture these organisms from the sample sent. Correct. After processing the sample which has been sent in a proper way. Okay, in a systematic process, the sample is processed. Then this is cultured over the culture plate, which is a labor-intensive process. It's not easy to make a culture plate. There are many types of culture plates. We all know blood agar plate. There are many different types of culture plates, isn't it? Culture media. So once they put it on the culture plate, how much time will it take for the isolate to be identified? 1 day, 24 hours. But at the most, maximum 72 hours, or sometimes they will put it up to 5 days also. So it is from 1 day to 5 days, anytime you can get the organism information. Correct? So once the organism is identified by whatever system, whatever way they are trying to tell us the organism, this organism susceptibility report will come within another 1 day or 2 days. Correct? 1 day, maximum 1 day. So once the isolate has come, they will process it for susceptibility testing and they will give you the report of culture susceptibility. What is the sample sent? What is the isolate which has come? And what is the susceptibility of this isolate? Isn't it? To what antibiotics it is susceptible, to what it is intermediate, to what it is resistant. This is the report which we get from the microbiology lab. So it takes 48 hours at least to get the culture sensitivity report, thinking that the isolate will come within 1 day. Later 1 day for susceptibility test. So at least 48 hours we have to wait for the culture susceptibility report. Till then the patient will be on empiric antimicrobial treatment, right? So what are the possible outcomes? The microbiology reports will tell you once a culture sample is sent to them. What will they tell? In terms of the isolates, it can be, they can tell that they have identified a organism, and what is that organism? What is the other thing which you generally get? They could not, no bacteria, no organism has been isolated, a negative report. The third report is what? Contamination or colonization. Colonization could be one outcome, contamination could be another thing, right? So there are 4 outcomes here. One is positive, where you know the isolate, that's a very happy result. The whole effort which you have put to collect the sample, send it to the microbiology lab, processing the sample, getting an isolate is a very good outcome for the clinician and for the patient. A negative report, isn't it? It is double-edged. I'll tell you how a negative report is double-edged. The third is a colonization. At least we are happy that we know some colonizer is there and we don't have to treat it. Contamination, redo the job. Again, you have to process the sample, again collect the sample, again send it by sterile mechanism. So redo the job again. So these are the the main 3 are these: colonization, negative, positive. Contamination, you have to redo it. The process which you have done is wrong. So what are the possible reasons for getting a report of contamination now? Why will you get a contamination report? Container, the sterile container may not have used, you may not have used. At the time of collection, if you have not used a sterile procedure, there also contamination can happen. Then if in central line sample collection, there is a very big procedure to collect the sample. So you should be very careful when you are collecting the sample for the central line samples, isn't it? So you will have this contamination is because of that mainly. So the nurses have to keep a very good training in their own setup. Once they see that the percentage of contaminations reported by microbiology lab in their area are increasing, they have to retrain their staff. How to do? They have to identify where the lapse is coming in the sending the sample. They have to identify the source, and source control has to be done. Otherwise, Again, so many times redoing the procedure is a waste, and all the more is the patient is losing time, isn't it? We are not able to identify the organism for 4 days, 6 days now. It's a very bad outcome for the patient, and so many pricks to the patient, so much of sample waste is all very difficult. And what do you mean by resistant isolate? When do you call an isolate resistance? What do you mean by that? Once an organism, say Klebsiella pneumonia, has been reported to be resistant to ceftriaxone, that means what? That means, can you use ceftriaxone in that patient? No. So for whatever antibiotics listed in the culture sensitivity report, once a microorganism is flagged resistant, that means that antibiotic will be of no use in treatment of the patient. So you cannot use that antibiotic anyway. What is intermediate? What is susceptible? Yes, if they report it is sensitive, then you can use that particular thing at a recommended dose, in a recommended duration. You can use that particular antibiotic. What is this intermediate? Any idea? In between these two, susceptible and resistant. But what is the implication? Can we use that antibiotic or no? Add a susceptible. So you can use an intermediate. Maybe if there is another susceptible antibiotic there. So it all depends on the guidelines. If there are no susceptible antibiotics, let me say, no susceptible antibiotics, there are 1 or 2 intermediate and the rest are all resistant. Then this intermediate can be used at a higher dose, and that has to be given, that has to be very carefully given, because high dose is always attached with toxicity. Safety profile will be different. So you should closely monitor the patient for adverse events, and the high dose should be given guidedly, only on a prescriber order. Okay. Of course, sensitive antibiotic recommended dose also by the prescriber order only. So we will just see what is the impact of antimicrobial resistance in the current situation. The projected antimicrobial resistant related deaths by 2050, if we are going with the same kind of mindset, same kind of practices at all levels, say veterinary, agriculture, hospital, and a consumer, everybody is following the same practices, and we are not taking this resistant reports into our consideration, and if we are not acting upon them by changing our practices and mindsets, the projected AMR deaths at this rate by 2050 will be 10 million. What is now 7 lakhs will increase by 14 times. And people will, 10 million is the expected death rate from AMR, and that will become the leading cause of death in the global scenario. Already 33,000 deaths are happening due to infection by bacteria which are resistant to antibiotics. We have to all understand that whenever we are getting an isolate which is resistant to antibiotics, for which it was sensitive earlier, 10 years back, if we are treating such an infection, it is a very meager chance that the patient will recover. We are only hoping our best. We don't know whether we will be able to treat the patient or not. Only the recovery of the patient should tell us whether she or he will recover or not. It is such kind of a grey situation we are in. And 75% of the healthcare associated infections which are happening today are resistant to the antibiotics. So the biggest role of a nurse comes here. Hospital acquired infections are contributing to 75% of these resistant bacteria infections. So how are we going to improve our infection control practices at the ICU or ward will determine how much resistance are we going to bring down in our wards and ICUs. And given so many things which have added to our therapeutic armamentarium, like we are now treating patients who are immunocompromised, who are on immunosuppressants like tacrolimus, cancer therapy, where there is no immunity to protect them from the regular infections, isn't it? So such patients also we are treating. So in that case, the development of infections due to resistant bacteria will be furthermore, because we are seeing those organisms which are not generally pathogenic to human beings are also causing infections in these people. And we don't know which antibiotic will act for them also. That also we are very unsure for this opportunistic infections. So infection control takes a very, very predominant role. And this whole 2 days, I think they have brainstormed you with how the infection control and prevention should be taken care of to come down on this resistant infections. You will have to utilize all those tools to reduce the resistant organisms reported at your microbiology department. That is a indicator that your practices are very good. And that is the contribution you can give to the institute or to the hospital or to the patients that you are caring for. Unless the number of resistant organism reports reduce at your own setups, into your own work areas, you are not successful. So you should see where we are going wrong and what we have to improve upon. Where training is essential, train yourselves. Where learning is essential, learn. Where implementation is essential, you have to implement it strictly. By whatever way you can do it. All the ways we have to put our efforts. Antimicrobial stewardship is coming up in a big way. Now NMC has made it mandatory. National Medical Commission has made it mandatory that every hospital should have an antimicrobial stewardship committee and hospital infection control committee. Don't think that these people are coming to audit your things or they are going to they are going to criticize you for the practices which you are doing. Think them that they are going to help you how to get over these practices, and you will have to take them positively, and if you implement them you will only see the impact and you will get lot of job satisfaction, because you will see amoxicillin will come back in the empiric antibiotic therapy. That is the goal which we all should be looking for at this stage. And I want to tell you that out of this 75% of infections which are healthcare associated, 39% of infections are resistant to carbapenem, that is meropenem resistant. And a portion of this percentage are also resistant to colistin, which is the last resort antibiotic in India. Beyond colistin, we don't have any drug as of now. Recently, ceftazidime avibactam has got approved, but it is not still useful in all the carbapenem resistant infections. Again, to know whether ceftazidime avibactam will be helpful or not, you will have to do another test. Then only you will know whether you can use this antibiotic or not. So that 40% of this are going towards carbapenem resistant. We are moving from, in the gram positive, we are moving from MRSA to VRSA. Vancomycin resistant Staph aureus is also there. And now we are in that stage where we are forced to prescribe linezolid because of vancomycin resistant infections in the VAP, ventilator associated pneumonia. We have no choice, because that is the only antibiotic which will work. If linezolid also becomes, if organisms become resistant to linezolid also, there are a set of percentage of patients who are receiving daptomycin as on today. So let's not lead ourselves into that area where we don't have any antibiotic for our patient. Already there are isolates which are getting reported as pan drug resistant. None of the antibiotics on the susceptibility report listed 20-25 antibiotics. For none of the antibiotics, the organism will be susceptible. Everything resistant. What are we supposed to treat them with? What are we going to do with them? This is the big question which is on our heads. So we should only see that we will not lead ourselves into that situation. That is only in our hands. Once we get that report, we don't know what will happen to the patients. Probably the surgery was a bypass surgery. The surgery was a very good transplant surgery. The surgery was successful. Patient has developed a pan-drug resistance in the post-operative period. All the effort which you have put in for the transplantation, all the risk that the patient has taken throughout the dialysis sessions and the transplant sessions, the immunosuppressants, the adversity that he has gone through is all gone once a pan-drug resistant comes in a post-operative period. Khatam. Everything is gone. So whatever technology we have developed, whatever development we are doing in the medical side, if you want to have the benefits of all those things, infection control has to be done. There is no other alternative or substitute for that, at least at the hospital level. The veterinary people are doing what they can do. Agriculture people are doing what they can do. Parallelly, we should not wait that first let the veterinary people do, let the agriculture people do, then we will see. No. Parallelly, we have to work under One Health initiative which is taken up globally by the WHO. The One Health initiative is targeting the antimicrobial resistance in food, animal, and patient care, human health care. All these three things, if we are not parallelly beating them at the same time, microorganisms are going to win over us. Over our intelligence, microorganisms which are not intelligent at all will win the race. So we have to mainly do these three things. Three things which we can help is we have to use the antibiotics very prudently and only when necessary. Don't just use antibiotic as benefit of doubt. Only when absolutely necessary, the antibiotic has to be prescribed. And when it is prescribed, it should be used in a way it is prescribed, not like what we want or what we are convenient with. Okay? That kind of interaction only a nurse can do with the patient. How to take the antibiotic and how many times they have to take, what precautions they have to take, whether they have taken or not, how many days they have to take. The nurse has to educate the patient till the pharmacist come into this particular loop. It might take long time for us, for clinical pharmacists to come and enter into our setup and help you in this particular area, wherein they will tell the patients how to use their antibiotics, which one is an antibiotic, which one is not an antibiotic. Till then, I think nurses only are the direct link with the patients and they have to take it up. They have to educate the patients as to how many times, how they should take and what duration they are expected to take. Okay. Then the next thing is good infection prevention and control practices has to be, we have to learn, we have to train ourselves and we have to implement it and we have to show the impact. Then only you will reinforce this system in the coming nurses. Then only people will be motivated to take up these practices. Then research is being promoted by the global WHO itself, FDA, Indian CDSCO. Everyone is actually for research and they are allowing any research which is possible in this particular antimicrobial area. We are coming up, but in FDA already 4 or 5 drugs have got approved for carbapenem resistant infections, but still we don't have them in Indian market. So we have to be there, we have to fight with it till then. And even when they come, you can't use them like colistin or meropenem. They should be kept as valuable. Diamonds are very invaluable, precious weapons there. You cannot use them just like that. Only when it is, whenever a prescriber prescribes in a right way, you have to give. So everyone is responsible for addressing this antimicrobial resistance threat, including patients, doctors, nurses, pharmacists, veterinarians, farmers, and policymakers. Everyone has to step down. So whatever precautions they are telling you to be taken while collecting a culture sample, please take all those precautions, because a culture negative or a contamination will increase the patient treatment with a broad spectrum antibiotic, unnecessary treatment for another 2 or 4 days. Then what is the role of nurse in dispensing antimicrobials? It has to be given to the right patient. You have to identify the right drug. You have to be very sure that this is the antimicrobial agent that is prescribed. Give it through the right route with a sterile practice if it is an IV administration. Then at the right time. I have seen this practice. Before starting the antibiotic on the day itself, nurses have this type of documentation. They already mark 6, 12, 4 o'clock. Already the timings are marked on the sheet. Whatever timings. If it is a 4-time daily regimen, they already mark in the morning when they join the duty. 6 o'clock, 12 o'clock, 3 o'clock, 8 o'clock. And we don't know exactly at that time the antibiotic has been given or not. They just strike off. We don't know the exact time of administration. We can't track the exact time of administration from the nurses' charts. So please write the time at which you have administered, because this will help the clinician in understanding whether it was given in the appropriate fashion or not. Don't write it before and then just strike it off to say that 4 doses have gone today. 4 doses should be going. 4 doses have gone. When they have gone, was there the required 6-hour interval between them or not? is very, very important for certain antibiotics to be effective. So please change your practice. You have to write exactly the time at which that dose was administered in your records instead of writing. Yes, there is a question there. Correct. That's a very nice practice, actually. That should be the practice. That is what I'm saying. Actual scheduled time is what? Actual time of administration was what? If this can be maintained, the prescriber will have an idea whether it is going on time or not. That's I really appreciate your efforts. But we have seen in some. And that's what. And yes. So that particular interval is very, very important.
To overcome the resistance of the antibiotic. Also, I want to request you, madam, is assessing the quality of the drug, standard of the drug, because the most of the antimicrobial resistance is coming substandard drugs, substandard antibiotic. I am 100% sure, because every corporate hospitals, the doctor belongs to okay standard. Otherwise, whatever the hospital gives, they are yielding for that. That antibiotic is not working. So who is signing for that?
Actually,
Because one is FDA. I'm seeing how it tells levocitizine is not functioning for this one. So Bilastine has come into the place.
correct.
Bilastine is immediate effect. Running nose is
Working.
but levocitizine and citizen doesn't work. Going on, no levocitizine, no citizen is working. Bilastine,
It works.
the patient is giving a good response.
Actually, this is also our responsibility only, sir. We will have to ask the state drug controller because they have the analytic analysis procedures with them. We will have to send this sample to them and ask them to analyze it, and then only we can claim that it is substandard or standard. Because without knowing the exact composition of the drug, how much it should be and how much it is, whether the quality is there or not, we cannot just say arbitrarily. We have to prove it. So the onus is again put on the prescriber only. Due to all these duties which we are having already, so many duties which we are doing, this particular duty is also on the head of the prescriber. So this is getting overlooked actually. But there should be, if you have pharmacists in your corporate setup, clinical pharmacists, they can interact with the state drug controllers. There will be drug distributors there. You can send the samples to them, ask them for analyzing, because any hospital does not have a setup to analyze all the medications which we use. We may be having therapeutic drug services at Institute of NIMS, but we do only for a handful of drugs which are important for the certain conditions like anti-epileptics or immunosuppressants, for which demonstrated TDM services are recommended. But we don't do it for regularly for checking whether this is quality or not. That kind of setup we don't have. So it is the state drug controller responsibility to check these samples which we are sending. They do a random check from all medical stores of all the hospitals, all the pharmacies. They collect randomly samples from all the medical stores and do a checkup. And if you go to the state drug controllers, the CDSCO site, you can see from where the samples were picked up, and they are withdrawing those batches also wherever it is substandard. They are doing their job, but we will also have to contribute to it. We should raise an issue and we should send the sample to them. We will have to establish a mechanism for doing this.
Any substandard drug by
Yes, sir. Yes, sir. Actually, if you go into the website, they very clearly mention that this batch has been retrieved back from that pharmacy. They are doing it, but it is a random pick of 10 or 11 tablets from the whole pharmacy shop. There may be other things also which are there which they don't do. So this has to be our responsibility only to make it prudent, and we have to establish the substandardness if it is there. That, as of now.
My question to you is, okay, antimicrobial function.
That's what could be, as you are saying, could be the composition is not appropriate. There may be things, but unless we prove it by a proper analytic text. Never responded. We will have to send these samples to the CDSCO, sir. That's it. That's the only way we can do it as of now. But with whatever resources we have, whatever antibiotics which we get to administer at the ICUs or wards, whether it's in a corporate setup, branded drugs, or whether it in a government setup, whatever is coming to us by indent, that you have to do at least whatever we get, we have to do it properly. That is my essence. And that what that sister was saying is the best thing. You write the scheduled time, cross it off if it was not administered at that time, and write what was the right time of administration. So that at least the prescriber knows why it got delayed, so that those things, logistics can be worked out by the hospital administration people and see that the dose goes on time. So that is one thing. Duration of treatment is also very important. Generally, in the ward patients and ICUs, there won't be any problem because every day the prescription is revised. So that day prescription only you are giving. You are not bothered about how many days the patient is taking. But in OP cases, if you are there, you will have to exactly tell them how many days this antibiotic is prescribed. Actually, what they are saying to the prescribers is, the best way is to separate the antimicrobials from the regular list of other drugs in the OP prescription order. And so that the consumers will exactly know what are the antibiotics prescribed among the prescribed drugs. And at least we can insist that these drugs which are antibiotics should be taken for those 5 days. Rest of other things are all symptomatic anyway. They can stop it also when the symptom is better, when they feel better. But antibiotics are one thing which you have to take for the entire duration which is prescribed. So if you can separate the antibiotics from the list of prescribed drugs, the consumer will be aware that these are the drugs which I have to take. Rest of them I can stop whenever the symptoms resolve.
Also, you should recommend the government of Telangana or whatever government of India. There must be before administering antibiotic, they must take into the consideration of microbiologist and clinical pharmacologist opinion. If you maintain these standards, then only the antimicrobial resistance will be taken into the consideration. Otherwise, we are not going to stop antimicrobial resistance because no hospital is following this rule. According to their wish, they are starting the antibiotics, and even clinician, empirical antibiotics, straight away they are going with the meropenem with the colistin, and now meropenem gone. Everybody is starting with ertapenem, doripenem. So, and microbiologist, they have to take into the consideration of microbiologist opinion as well as clinical pharmacologist opinion.
Yes.
That is the most important. You have to set the guidelines for that.
Correct. The state, fortunately, Telangana state is coming up with I'm hoping that they're at least working on that. The state action policy for the antimicrobial resistance might come to us. Already a national action plan is there, but state action policy is also coming up. And this hospital infection control committees and antimicrobial stewardship committees at all hospitals, which has been made mandated by the NMC, at least in the teaching institutions, they will have to establish their own hospital antibiotic policy for which all clinicians have to be compliant. There is no other way to get through it. Because in the antimicrobial stewardship committee, you will have pharmacologist, microbiologist, everybody. So they will decide in consensus with the treating clinicians what should be prescribed if there is an upper respiratory tract infection. What should be the empiric? What should be the definitive? What should be prescribed for a lower respiratory tract infection? Every infection will have a set protocol, and that has to be done. I mean, no physician will get any other is allowed to prescribe any other drug beyond that unless it is justified to use that particular antibiotic.
The auditing of that
Yes.
antimicrobial agents usage every month, each and every hospital.
Correct.
Because in city, especially in twin cities, they are using inadvertently.
Correct.
Inadvertent use of antimicrobial is giving a lot of resistance.
So these are called point prevalence studies, sir. Again, antimicrobial stewardship committee has a responsibility to do this point prevalence study every month once. They will have to see whether the clinicians and the nurses are complying with the sending of the cultures, whether how many contaminations have come, what corrective action they have taken. On the side of prescribers, they will see whether they are compliant with the policy that has been drafted or not, and whether a justification was given for changing the drug. So everything is going to be accountable. It's not going to be like we were in the last 10 years. The things will change. We will have to adapt. We will have to learn. We will have to become aware. How are we going to change our mindset to it? And we should all accept it, thinking that this will bring welfare to the patients to whom we are serving. Then during administration of medications, what all the things which you have to check, you have to double check whether the same medication you have picked up is correct or not. Next, you have to see whether it has to be diluted with sterile water or normal saline or ringer lactate. You should have adequate knowledge of that. The third thing is you will have to check the manufacturing and expiry dates 100% before giving any medication. And if possible, you will have to do a test dose if the patient has not received it before to prevent the hypersensitivity reactions. And while dispensing oral antimicrobial drugs in inpatients, I have seen in government setups that they hand over the tablet to the patient and say, this is for you to take. The patient may be not in a very good way. I mean, he may be sick. The patient attendant will get the tablet. And the sister goes to them and says, this tablet has to be taken in the afternoon, 1, 2, 3 tablets. They leave it with the patient attendant. What happens? We have seen the attendant changes. And these tablets fall below the couch. The next attendant who is coming on shift basis to attend the patient does not know this instruction. So please, whenever patients are there in the ICUs or wards with you, for oral medications, you have to stand there and you will have to supervise that the drug has been taken. Then only please record it that the drug has been taken. Please don't leave the medications with the patient attendants, because if the attendant might insist the patient to take, the patient may say, another 10 minutes later I will take. This is a common thing. But the attendant will place them on somewhere and the next attendant will not even know that this particular drug has to be given and gone. The nurse will record that drug has been given. So we don't know whether the treatment failure is due to non-compliance to the therapy which is prescribed, or is it due to whatever causes, isn't it? Non-responding microorganism. So please make it a very strict thing in all your setups that you will do it at direct supervision, at least when the patient is in the hospital. We can't do it at the home level in outpatient, but at least we can do it in the ICUs and wards. So parenteral antibiotics, whenever you are administering, you have to take all sterile precautions, because we are actually meddling with the lines, IV lines or IM. So please see that the practices are perfect, and please train the new group of nurses whenever they come into your setup. It will be a refresher for you who are training, and it will be knowledge for those who are coming into the setup. They will also know what processes are there in that particular setup, and they have what are do's and what are don'ts if they have to work in that setup. So the specific precautions would be you have to perform active monitoring or initiate antibiotic treatment based on the provided orders. And always, if the clinician writes send culture and empiric antibiotic treatment, first collect the sample, then initiate the treatment. First dose of antibiotic administered time should be recorded in the nurses' notes, 100%. And the culture collection time should be recorded, 2 minutes, not 2 hours. 8 a.m. nahi chalega. 8:31, 8:32. When did you take the culture? 8:35. When did you give the antibiotic? Both times, first dose of empiric antibiotic and the culture collection time should be recorded to the minutes level. And this has to be practiced standardly to know whether the culture negative is due to the sending of the culture after starting empiric antibiotic or the isolate is not present, whether the infection is present or not. What will happen? The empiric antibiotic has started today. After 6 hours or after 1 day, you send the culture tomorrow, let us say, due to some reason. Already the antibiotic 2 doses have gone for 24 hours or 48 hours. Probably the culture negative is telling you that the antibiotic is effective. But what happens to the prescriber? He will think that there is no bacteria. So it could be viral and starts an antiviral or an antifungal. This will add to number of drugs the patient is receiving. So please make it sure that the culture has to go before the first dose of empiric antibiotic. Otherwise, the culture report which has been generated by lot of labor-intensive processes is all a waste. Because it will come negative and it will create confusion. They may change the antibiotic now, isn't it? They may have been thinking that there is no bacteria, so they will change the antibiotic. The patient is not responding. Many more things will come into the antibiotic prescription. So when initiating the antibiotics, review the dose and time of dose schedule for accuracy and check for history of allergy before administration of that particular antibiotic or any other drug. When cultures are ordered, you have to obtain cultures before starting antibiotics and document the time of culture collection and send them to the microbiology laboratory. Then monitor culture results and reports. Monitor these culture results and report the results to the physicians. It is your duty to say that the culture report has come. Because the culture report can come 1 day after, 2 days after, 3 days after, 4 days after. It is your duty to tell that the culture report has come and you will have to remind the prescriber whether they want to review the antibiotic treatment. You take proper orders from the prescriber and go ahead with the schedule. Then ensure proper techniques when collecting a culture. Perform a formal antibiotic timeout at 48 to 72 hours after starting antibiotics using a standard format. That means that after empiric antibiotic treatment, you will have to remind yourself that the culture report might have come and I have to get it. After 48 hours, after 72 hours, you have to interact with the laboratory and get the report and share it with the prescriber, whoever is on duty. Report clinical progress, lab findings, culture sensitivity report, including the bug-drug mismatches to the providers. If you see that the patient is on a drug for which the organism is resistant, that much you understand that this drug is not working. So it is your duty to tell them the report has come, it is resistant. Even if it is susceptible and there are other antibiotics for which the drug is susceptible, let us say. In addition to meropenem, it is also susceptible to ceftriaxone or ampicillin. Then you will have to tell the provider that in addition to this, these are the drugs for which the microorganism is susceptible. The report is available. And you will have to tell them to review whether there is a chance. You should ask them whether we can review the antibiotic prescription for this patient. So make changes in the isolation precautions if necessary. Whenever you see a MRSA, whenever you see a ESBL, whenever you see a CRE, carbapenem resistant isolate, you will have to isolate this patient from the regular patients because that will be mostly a hospital acquired infection. So next patient may develop. The chance of the patient next to him to develop the same infection are very high. So try to take isolation precautions as far as possible. Take your hospital administrator's consent and do that according to the hospital policy. So in addition to these precautions, infection control practices has to be in place. If you do all these things, checking the antibiotic, reviewing the antibiotic, changing the antibiotic, stopping the antibiotic, everything is correct, but infection prevention is not in place, the number of resistant organisms which are coming from your ward will never reduce. It will always increase. So please see and make standard treatment, standard operating procedures for floor cleaning, for checking the IV line. For every procedure a nurse is supposed to do, you should have a SOP on which other nurses will do the same thing. The compliance to the SOP should be checked by the nurses themselves. And whenever there is a breach, you have to retrain the individuals. Like that, you will be able to see whether there is a standard operating procedure for something and whether that is followed or not. This has to be checked time to time, and an action, corrective action has to be taken whenever there is a breach. So nurses are instrumental in management of antimicrobials, especially in prompting, reminding, checking, and querying prescriber decisions. You will have to come forward. You will have to interact with the prescriber. You have to tell them that this is resistant, why, but still this patient on this drug. Kindly review this. You will have to query. Okay. Nurses have a role in educating patients. They have to communicate and manage the other staff with whom they are working, who are doing the floor cleaning or the bed cleaning or the patient to patient management. If they are doing, you have to tell them that they have to do a hand hygiene, whatever the microbiologists are telling you the best way to do it. Then collecting and sending appropriate biological samples with adequate precautions. Follow up the reports and inform the physicians. Documentation of time of collection of samples and time of administration of antibiotics is very, very important. Otherwise, we will not know why culture negative has come. Okay? Assessment, monitoring and reviewing of prescriptions, durations, dosage, and initiating antimicrobials for septic patients and initiating intravenous to oral switch. That also nurse has to tell. Now the patient is able to take oral feeds, sir. Yesterday night we have initiated. Can we shift the IV to oral route? Because IV is associated with many other problems to the patient. It can trigger another hospital acquired infection also. So better to switch to oral as quickly as the patient can take the oral feeds, and that will be in your knowledge, isn't it? When the patient has started to take oral feeds. So you can intimate the doctor that can we do a IV to oral switch. It's always safe for the patient and for the prescriber and for the nurse too. So they are very crucial. The nurses are very crucial to curb the threat of AMR by improving judicious use of antimicrobials and implementing hospital infection control, prevention and control policies. Thank you so much. Yes, here we don't have a separate thing. Microbiologist is here. When you send a sample for culture, do you do aerobic and anaerobic without asking for it? Is the question. If there are any queries, I can take. Actually, we have a hospital infection control committee in place, sir. We have an antimicrobial stewardship committee also in place. We have a running ICMR AMSP project also. We are now getting trained. We are in a process we have developed the first version of the hospital antibiotic policy, but we are revising it again, updating it again. So we will, no, we have our own rate contract policy on which we get the antibiotics. So the hospital has a separate rate contract, sir. No, we procure it ourselves. Because ours being a tertiary care hospital, many of the drugs which are there in TS emergency may not be sufficient for us. we will have to have more advanced medications for cancer or various other type of patients that we are treating here. No, sir. We don't assess the quality of the drug, but from the medical stores, the drug inspectors do pick up samples randomly, and they are doing that analysis month-wise. So we get those reports to us. But we always, even now, we are also struggling with that. Whenever there is a substandard doubt, we are unable to process it. We also don't know how to go about it. So we are also seeing how best we can help these clinicians with. No, sir. But they do give us a report. That we will have to, the state drug controller only has to answer, sir. We will have to have a forum with him. Maybe we will do our best. We are doing our best actually. We will also interact with the state drug controllers in this particular regard. So if there are no queries, I thank you all for actively participating in the interaction with me. Thanks a lot.
Thank you, Dr. Radhika, for your extensive presentation. And I request now Dr. Nageshwara sir once. Sir is from the professor and unit head of General Medicine Department. I request sir to give his few valuable words over the infection control program. How the healthcare, please sir.
Thank you, Padmaja. I told just I came now only. I don't know what happened, what is happening since 3 days. But I'm medicine professor HOD. Madam, her husband is a DM hematologist. He's a close friend. We know her. He is left from here. He is practicing outside. With that respect, she is calling me because we are very close to me. I'm there in Nizam since 30 years. So we joined in 92 in Nizams. Now I am professor HOD. So I don't know. This is an infection in, especially in our country. When compared to any other country, it's, I think, there is no comparison of any institution, state, person, department, even hospital to hospital. Lot of variability is there. That's why still we have not standardized whom to follow, where to follow, what to follow. With a lot of contamination is there everywhere. What is the true organism? What is the false organism? See, always microbiologists say that follow the culture sensitivity and rule. We don't get more than 60 to 80%. Even the patient is having septicemia, we don't get anything. Even pus is there, we don't get anything from the pus. When the pneumonia is there, I'm telling you 80% we don't get from anything from the sputum. See, theoretically it looks good, but practically it's a problem. I'm talking about my angle. I am not talking about prevention and other things. Prevention is a big issue. I told you now, the country itself is a very friendly environment for the bacteria. If you talk about other countries, the virus will dominate. If you say diarrhea, they say viral infection. But it's not possible. Same thing is not in our country. You have to take anti-amoebic or anti-infective drugs. So issues are, I say, there is a lot of difference, especially when infection. I'm telling you as a senior person of medicine, there is no controversy in the medicine where there is an antibiotics and infection is concerned. If there is MI, there is a clear-cut guidelines. Give this anti-Z, that and this requirement, and there are 4 or 5 drugs, you can fix it and go out. But same thing is not possible when you are treating infection. So there are a lot of things you have to consider. Somebody asked whether to do what cultures, either gram-positive, gram-negative, even fungal cultures. Itself is a lot of question. So there should be a lot of communication to us. When you ask the specimen, whether they have done all or not, all available or not, whether you have to ask specifically it is or not. Because we are not all experts in sending even sample also. So sorry, somebody is telling that there is antibiotic itself is a problem. Recently I'm talking the same thing. You are sterilized, but there is no guarantee about your sterilization. You are given antibiotic, there is no guarantee about your things. When the things are itself is our country, especially false production is many. Where is the standardization of our everything? Even culture material is correct or not, we don't know. Whether the sand thing is correct or not, we don't know. Whether drug is correct or not. There is a lot of questions. I say everywhere, unless there is improvement and commitment, it is highly impossible. I say there is a flora of another 2 millimeter, 2 centimeters flora is moving with the bacteria here. You cannot say that this is organism here, there or not. Even everywhere, where you can, we can call it a sterilized zone, there is a plenty of bacteria. So it is difficult to eliminate by a single method, single person, single process. We are taking hand hygiene in the wards correct, but what are the patient contamination? The blankets, diet, hand, duct, bread, gid, everything. So difficult means I think that's why I don't blame anyone for anything else. It's overall. Everyone is contributes, not the microbiologist, not the physician, not the clinician, not the nurse. Even patients, everyone we have to contribute. This is a loaded. This is this is me. The country itself is a big source, growth source for the bacterial growth source. You can call the environment is friendly environment, reproductive environment like human environment. The bacterial environment is also very friendly for the bacteria. So highly impossible to control this infection. I think very cautiously everyone has to work hard and take care, not to blame anyone for anything. That's the thing what I say also. So if any questions is there, I can answer rather than talking my own words of my experience. I know that I say in the Nizam Institute, I don't blame that government hospitals are not doing anything. We are not doing anything. We are all same, only small little bit difference of our attitudes and our culture, availability of facilities and so first cleaning material and so many are there. So nowhere we can say I came from a government college. The Banavan is there, my classmate. She's a microbiologist. So from Angara Medical College I came, but we don't blame them. We don't get anything great here also. Because there are many issues when you talk about it. When there are everything is there, you will also do same thing. What I say. So there should be a lot of things to have to improve. Any question is there, I can answer. But anyway, madam is called. I go in a different direction. I don't have any contradictory things. I'll talk my own way. I am not blaming anyone because it's not. It is a country. For anything, everyone is responsible. It's not one person you have to target it. There's nothing is there. Okay, sir, anything is there? You can ask from my side as a clinician. I can talk. Otherwise, I think I can say thank you, everyone. Thank you, Padmaja.
Capsi and cortisol. Then it comes to question of multi-drug resistant organisms. After that, you can visit and discuss what manual somebody have not signed in the register attendance register. So whoever have not signed, please do. Yes. We have given, but there are few conflicts are there. Please fill them once. Otherwise, certificates will not be received who have not done their signatures. That is important. Actually, certificates may not be today. Actually, they are there, but signatures have not been done yet. So you may get late. Wednesday, we will send to DME. Through DME, you will be getting the certificates. All signatures are necessary. No, without signatures, we cannot issue.
మైక్లు ఆఫ్ చేస్తున్నాయి రెడీ చేస్తున్నా చూసు
బాక్స్ ఇవ్వాలా
Yeah. Folder. प्रेजेंटेशन है ना, तो कॉपी करके दे।
कौन सा?
ये फोल्डर पूरा कॉपी करके मैडम को देना।
अच्छा, वो फोल्डर।
हाँ, ऐसा नहीं मैडम, पोस्ट करना, राइट क्लिक करके सेंड टू। हाँ, यूएसबी नीचे नीचे।
Good afternoon, everybody. Now I invite Dr. Neelima, Associate Professor from Microbiology, to present on catheter-associated urinary tract surveillance and also central line-associated bloodstream infection surveillance. It is a bit, you need to concentrate on this surveillance. Why? Because you can perform in your own hospitals, how to go with it. Okay, thank you.
UTF पहले ओपन कर राइट लाइट का जरूरत नहीं है ये लाइट इट्स ओके आई एम स्टार्टिंग विद द टॉपिक अच्छा अच्छा ओके Shall we start or we shall wait for some more time? Okay. This is a very dry topic and post lunch, I know it is even more difficult. So we'll keep it more of interaction rather than a lecture kind. So objectives of this session would be, I'll be describing the key terms. This is about the surveillance. So I will be discussing about UTI surveillance as well as BSI surveillance for the next 1 hour. The surveillance is important. Once you go back to your hospitals, please do the surveillance. Based on the surveillance rates, it will help you how to improve on those aspects. Okay, so we will be defining the case definitions. I will show you how to fill those reporting forms and how do you do the analysis and correctly apply. Okay, if everybody is ready, we will start. Okay. Yeah. So UTIs are the fourth most common type of healthcare associated infections. All the other health associated UTIs are caused by mainly because of the instrumentation of the urinary tract. So indwelling catheter increases the risk of this hospital-acquired infections further by about 3% to 7% per day. So let us see what are the case definitions for surveillance purposes and how does it differ from a clinical diagnosis. Anything at the back there? Yes, you want something there in the back? No? Pay attention, okay? Okay, how does the surveillance case definitions differ from clinical diagnosis? So surveillance is basically you want to identify the trends in population, whereas the clinical is particularly to that particular disease or the patient. So we'll go with the case definition. So you need to satisfy here 3 things: culture criteria. If it is a catheter associated UTI, then the catheter criteria, and the symptoms, clinical criteria. So microbiologically confirmed UTI. So patient must be having signs or symptoms of UTI, and also it should have a positive urine culture. So the laboratory will be helping you in establishing the diagnosis by doing the cultures. They will give a quantitative cultures. You know that more than 10 power 5 CFU per ml is a significant bacteriuria. So the specimen you will have, I'll be focusing about the specimen collection here. You will have to take the freshly voided sample. Generally, in a morning sample would be better. It should be a clean catch and a midstream urine sample. So this also had to be taken care if you want your surveillance to be a good surveillance. Just, I think you all know the kind of samples which we receive to the laboratory. I think even more than 70% will be just, do you think they are appropriate samples? No. So first this has to be improved, then you can go to the surveillance. Without improving your specimen collection, just doing surveillance will not be of much use to you. It's all waste of time. So once the sample is collected, so microorganisms usually do grow very rapidly in urine at room temperature. So see that the sample is transported to the laboratory within 2 hours. Or else if it is more than a day or where the laboratory is very far, it can be refrigerated for about 24 hours. Or you can use a boric acid preservative. So the rejection criteria would be more than 2 hours without refrigeration, 24-hour urine sample, and sample collected from the bag. I think if you focus on that, catheter samples will be mostly from the bags. So that is of no use. So you will have to, in microbiology aspect, you will do a gram stain. You will have to look for the bacterial count, the leukocyte count, and any epithelial cells are there. More number of epithelial cells, it will indicate contamination. You can have the automated systems like this Vitek. Nowadays, I think every hospital has this. So how do you interpret? So if it is only one isolate, at least if more than 10 power 4, I think for the surveillance purpose, we are taking 10 power 5. So I'll skip this slide. So at least 2 isolates with more than 10 power 5, you will be going ahead. If more than 2 isolates, you consider this as contamination and you don't do any surveillance. Okay. So I'll give you the examples here. A single urine culture with more than 2 organisms identified is routinely regarded as a contaminated culture and is not used in the surveillance. Like for example, you have Klebsiella pneumoniae, Escherichia coli. How many are microbiologists here? And any other clinicians also are here? Okay.
Klebsiella pneumoniae, E. coli, Citrobacter, if these three organisms, this is an example given here, if these three organisms you have isolated from urine culture, I've given some date there. So this culture should be considered contaminated and then you should not use it for further surveillance. If more than 2 organisms are isolated over multiple urine cultures, the culture can be used to meet the UTI surveillance case definition. Like for example, I've given here Klebsiella pneumoniae and E. coli are isolated from urine culture on 1st September. So you have 2 organisms there. And then there was Citrobacter on 5th September. So they are like, it's in the same, on the same day, it's not 2 organisms, not more than 2 organisms, okay? So this can be investigated. Now look at here, which urine cultures can be used for UTI surveillance. So on 10th October, you found it to be a mixed flora. 12th, only Escherichia coli was isolated. 14th, 3 organisms, Escherichia coli, Acinetobacter, Lactobacillus. 15th, 2 organisms, Candida and Klebsiella pneumoniae. So which urine cultures you will be using it for further surveillance among these? First one, will you go for the surveillance? It's a mixed flora. Okay. Second one, it's only one isolate. Will you go for the surveillance, further surveillance? Yes or no? No? Why no? Only one organism. Okay. And next, you have 3 organisms. So as per our case definition, will you go for further surveillance? No. And next, it is 2, Candida albicans and Klebsiella pneumoniae. Candida itself, again, is a different thing in a UTI. We are not going into those details. But then, as per the surveillance definitions, 2 organisms, you're going with the surveillance purpose. Okay. So a positive urine culture with not more than 2 organisms, at least one organism, out of those 2, if one has at least significant colony count, more than 10 power 5, you can consider. And these following signs and symptoms like fever, suprapubic tenderness, urgency, frequency, dysuria. So this is the clinical criteria. The microbiology criteria we already discussed. What was the microbiology criteria? Not more than 2 organisms, at least one organism more than 10 power 5. What is left? Catheter criteria, if at all, if we are also discussing about catheter associated UTI. So we have like this, the various categories. You have symptomatic UTI, asymptomatic bacteremic UTI. So symptomatic UTI is again as classified as catheter associated or non-catheter associated. Okay. So what are the criteria you will look for? So if you see this, think that this is having a catheter. So patient is having, so A would be catheter associated UTI. Same SUTI 1B will be non-catheter associated UTI. So catheter criteria, what it should be? Criteria should be in place for at least more than 2 days. Okay. To fall it into the surveillance criteria. Or if it is removed at least a day before the date of event. What is date of event and all, I will be discussing further. But if these 2 are there, then you can, your catheter criteria is satisfied. So you can say that it is catheter associated UTI. And then with the clinical criteria, which I already discussed, so any of these symptoms, and then with the microbiology criteria with the colony count and the 2 organisms. So if patient is on catheter, he cannot complain about the frequency, urgency and dysuria. So those things you keep in mind. This is the category 2, when the age is less than 1 year of 1 year. The before criteria is for the more than 1 year and anybody beyond that. So patient less than 1 year, the symptoms will be little different. Rest all is same. So you have fever, you look for hypothermia, apnea, bradycardia, lethargy, vomiting, and suprapubic tenderness. So all this criteria, it has to be satisfied within that window period. What is this window period? Well, I'll be discussing. It is not like if it is beyond window period, then you cannot say though the criteria is satisfied, then you cannot consider that for the surveillance purpose. Because you want to know whether the infection is during that period, it's healthcare associated. Why we are doing all this, you want to know healthcare associated infections and how you want to bring it down. There is one more criteria called asymptomatic bacteremic urinary tract infection. In this, if it is with catheter, you will call it as catheter associated, otherwise non-catheter. So patient has no symptoms here, but then urine culture is there. But the same organism, think that in urine you have isolated Escherichia coli. Even in blood, the same organism is isolated. Then it's called asymptomatic bacteremic UTI. Same organism. If it's a different organism, then it will not fall into this. So now we will move on to the terms. So you will be coming across terms like window period, event time frame, or repeat infection time frame, it is called as. So what is this and why we have to know all that? So we'll be discussing. So I said the window period will be, what is a window period, by the way? Okay, so it's from the clinical to the test which is detecting for us. So that is called as window period here. Usually for the infective diseases, we have taken, it's not you or me who have taken, the CDC and WHO has given the guidelines. We are just following those guidelines. All this is from the CDC, what we are discussing today. CDC, WHO, ICMR guidelines. So usually the window period is 7 days. So how this is built up? So if you, in this case, you will take, like for example, the date of event. The date of event will be the test which has detected either that, or if the symptoms, if the symptom comes first, then that becomes the date of event. But then if you have sent the sample to the laboratory and then the symptom had come, then the date which you have sent the sample to the laboratory becomes the date of event. Is it clear or you want me to repeat? Clear, na? Okay. So sorry. So from that date of event, 3 days before and 3 days after becomes your window period. That is how you calculate your window period. So whatever your criteria, like your clinical criteria, your microbiology criteria, or your, what is the other criteria I said you'll have to satisfy? 3 criteria, catheter criteria. So that should be within this window frame. Then only you will attribute the infection. Otherwise, no. Now, okay, how do you set the window period? This is an example. Microbiology lab calls you on 13th September to report that a urine culture collected from a patient in ICU on 12th September is growing Klebsiella pneumoniae. So how many zeros? So it is 10 power 5 CFU per ml and E. coli around 10,000. So 2 organisms here and 1 organism with more than 10 power 5 colony count. So based on the results of the culture, should you investigate this as a potential UTI? Yes or no? If yes, then what is your window period? One of you can volunteer and answer this. I have not given here the clinical criteria and all, saying that it is all satisfied, you think. So 12th September is your date of event. Okay. So 3 days before, 3 days after. 9th to 15th. Okay. So will you go ahead with this? So why? That is clear. You have 2 organisms, still you want to go ahead, I'm asking. So 2, it's not more than 2, you have only 2 organisms. And in that 1 organism is showing more than 10 power 5. So your microbiology criteria is met. So you will go ahead with the surveillance. So you should know, surveillance is not like anything is it possible to do the surveillance for all the cases? So you need to have some criteria, what cases you will do the surveillance. So that is why these guidelines have come up. That's why we have to follow them. Okay, these are the universally followed guidelines. Yeah. So coming to the date of event, the date of event is nothing but the first element which is used to meet the criteria for the case definition occur for the first time within the window period. It could be either the clinical symptoms or it could be the sample. Whichever comes first, that becomes your date of event. See, I've given here, the urine culture is collected before the signs of symptoms. Then date of the culture collection will be the date of event, not the date of symptom. Okay. You have already said 14th, 9th to 15th, so that is correct. Okay. You review the chart of the patient in the previous example and find that the patient complained of urine frequency on 10th September, suprapubic tenderness on 14th September. Patient meets the UTI case definition. What is the date of event for this UTI? So 12th September, previously we discussed that it was urine sample was sent on 12th September. There I didn't give you the clinical criteria. So your date of event was 12th. Now in this case, what will be your date of event? 10th. So 10th September was your clinical symptom. So all this is falling in that window period or not? Yes. Your culture being collected, your symptoms. So everything is in that window period. Then only we'll consider. If your symptoms are much before window period and then very later you have collected the sample and sent, then that is of no use. Okay. See that it falls in that window period. Okay. Yeah, this is like you will also have to differentiate the healthcare associated infections from present on admission. POA is present on admission. So for this, the date of event should be more than 2 calendar days after the hospital admission. So I said, while we were discussing catheter criteria, patient is admitted and if he's on catheter for more than 2 days, then only we consider that. So then it can be attributed to the healthcare associated infection. But then if the date of event occurs within less than 2 days, then you will say that it is present on admission. It is not hospital acquired. It could be even from the community. That is how you will have to differentiate whether it is present on admission or it is in hospital acquired. Okay, so it becomes important to differentiate that. Now coming to event time frame. So what is this event time frame or repeat infection time frame? So they have given 14 days. It is not like that is a fancy number which you like or me like. It is given by again the CDC, ICMR and WHO. So it is usually taken as 14 days time frame for one particular patient. It is like that event. If repeated events occur in that period, it is not considered as a one more event. Only after 14 days, if an event, if it repeats, then it can be considered as one more event. So whatever time frame, like it is given as 14 days. How do you calculate this? Your date of event will become the day 1. From that day onwards, you will go 14 days. So that becomes your event time frame. Okay. Like for example, Escherichia coli has grown on, for example, today is what? 24th. 24th September, Escherichia coli has grown. And what will be the event time frame from now onwards? 14 days means? Ninth, 7th October. That is right answer. So during this, for example, now Escherichia coli has grown. And after a few days, if you have grown some other organism, so what you will do in the surveillance is, your event will be one event only. You cannot take it as 2 events. You will say that one event and it is Escherichia coli. But you can have added form of some other organism, for example, Klebsiella, that you will add, but you will not call it as one more event for that patient. Okay, is this clear? So look at this example. Okay, here the date of event is on 25th September. That is like how I have given just now 24th September, you said 7th October. Here it is 25th, it will be 8th October. So during this period, you cannot have new events. It will be only one particular event for that patient. Look at this case scenario. On 3rd July, a 46-year-old patient was transferred to the ICU after 2 weeks on the cardiac ward. Okay. So patient was already admitted. He was there in hospital for 2 weeks. After 2 weeks, he has been transferred to ICU. On 6th July, the patient has temperature of 38.3 degrees and blood and urine specimen are collected for culturing. Blood cultures are negative. Urine culture is positive, about 10 power 5, showing Klebsiella pneumoniae, Citrobacter fruendi, and Escherichia coli. So we have 3 organisms. So what is the date of first positive culture here? Yeah, 6th July. Was the UTI case definition met here? No, you will have to explain me why no. Okay, microbiology criteria is not met Somebody is telling it is 3 organisms. So we consider only 2, not more than 2 or 1. Okay, good. Then clinical criteria is met here. Yes. Patient is having symptoms. Is it hospital acquired or you will treat it as present on admission? Hospital acquired. So while transferring also, see sometimes patient keeps on multiple locations, he will be shifted. Some days he'll be in one ward, some days he'll be in ICU and again post-op ward, something like that. So in that case, what you should do is the date of event, whenever that, whatever the, when you know that clinical symptoms have been, when clinical criteria has been met, when you know that this is the date of event, so the date of event previous day or on that day where he is. So you will attribute that infection to that location. Okay. Is it clear or something confusing? For example, you take that he was in ward for a weekdays. Okay. And then after weekdays, he was shifted to ICU. So today is 24th. He shifted to ICU today. Otherwise, 17th, he was admitted in hospital. So today he shifted to ICU and then he started developing symptoms of UTI. So whatever your date of event or the UTI event which you are calculating, this you will attribute it to the ICU or the ward. This is what I was asking. Why ward? I said 1 week, na? Today the date of event has occurred. So the day on the day on which date of event is occurring or just 1 day before the date of event, wherever he is, you will attribute it to that new location, not to the previous one. Okay. Okay. Inclusion criteria, again and again, it is the same. So date of event should be more than 2 calendar days from hospital admission, or your surveillance unit admission should be more than 2 calendar days. And date of event does not occur within the event time frame of a previously identified UTI. Now, one more case scenario. 79-year-old patient was admitted directly to ICU. So here the direct admission is to ICU, is not shifted from ward and then to ICU on December 10th. Patient has no history of previous UTI. On January 8th, a urine sample was collected and was positive for Escherichia coli 10^5. Chart review revealed that patient had diarrhea and a temperature of 38.5 on January 7th. Does this case meet the inclusion criteria? Why no? Why no? Yes or no? No? If no, why no? If yes, tell me also why yes. Yes? Okay. Tell me, sir, why it is yes? Okay. Okay. The date of event here it is? January 7th is the date of event. So what will be your window period? In between 4th January to 10th. So your urine sample was collected on 8th. Your date of event is on 7th. So it is falling in that window period only. So definitely it meets the inclusion criteria. Yes. So it's clear then. This side is some confusion. If there is confusion, you want me to repeat, I'll repeat. So since then he was in hospital. Okay. Catheter, we have seen the catheter criteria is it should be more than 2 days, or when the catheter was in place for more than 2 calendar days, but it was removed on the date of event or the date just before the date of event, then also you will call it as catheter associated UTI. Okay. More than 2 days, it's clear. It has been more than 2 days, but it was removed. If it is removed on the date of event or a day just before the date of event, you still take it as catheter associated UTI. Catheter is not there. I will not call it as catheter associated UTI. No, it is still a catheter associated UTI. Much beyond that, then you will not say that it is catheter associated UTI. You will just say a simple UTI. This is, look at this example, a urinary catheter in place for more than 2 calendar days on the date of event, with the day of device placement being day 1. On 21st October, he had fever, E. coli. So in this case, that catheter was it more than 2 days, right? Because date of event occurred 21st October. So 19 being the day 1, so it was almost 3 days. So it is catheter associated UTI. So see the other example. On day 18, patient was on catheter for 18 days. On day 18, the catheter was removed. So that was, the date was 5th November. On 6th, he developed symptoms and then culture was positive. So though, because just I told you, no, date of event 1 day before the catheter is removed also, it will satisfy the catheter criteria. So still you consider this catheter associated UTI. Look at this example. You have identified a patient who meets the UTI case definition with date of event on 5th October. Patient has been in ICU since 1st October. Patient had a Foley's catheter placed upon arrival to the ICU, that is on the 1st October itself, which was removed on 4th October. So do you consider this as a catheter associated UTI or non-catheter UTI? Yes? Yeah, just a day before date of event, so it satisfies that. Very quickly, COTI prevention. So it has to be, catheters has to be inserted for appropriate indications only. Unnecessarily, catheters has to be not inserted. And nowadays, I think there's a practice where most of the times nurses do they insert catheter or they are depending on the workers? See that, please, workers should not do that. Nurses definitely has to follow the precautions and see that it is properly placed, properly secured. Okay, the bag should be, that's what, male nurse. Okay, it is only the doctors. Okay, for male patients, only doctors who can put the catheter. Yes, only doctors. Okay. So that also you please note it. I know this practice many people are not following. That is how it will land up. Yeah. You will rupture. Okay. So, but I think most of them don't follow this. So this has to be strictly followed if you want to bring down these UTI rates. Okay. Perform hand hygiene before insertion. Obtain urine samples using aseptic technique. Always maintain a closed drainage system. Secure the catheter after insertion. Maintain unobstructed urine flow. Keep the collection bag below the level of bladder at all times. Many times you see a patient, if he is shifted for some investigation, the bag will be lying somewhere. So always it should be below the level of the bladder. Empty the collection bag using aseptic technique and limit the duration of catheterization. Once it is not removed every day, so infection control nurses, whoever make the rounds, they will have to remind the particular doctor or the nurse whether the catheter is needed for that patient. You can give some kinds of alerts. If it is not needed, then they will remove it. So how you would do the surveillance? You'll have to follow with the microbiology department. You'll have to check the logbook. You'll have to look for the culture positives. And then the surveillance team will see that whether clinical criteria, all that has been met. And then you will have to go ahead with the surveillance or not will be decided. And then all these details have to be filled up, which I'll be showing. I think you cannot see, I think. Out for you. So this is a flow chart. First, you have performed a urine culture. You look for whether urine culture is done or not. Yes or no. No, you don't have to report. If it is yes, then you will look for how many organisms been isolated. If it is one or just two. If more than two, you will not report. If yes, only two and or only one, then what you will do? You will give a positive urine culture, and in that at least one organism more than 10 per 5 colony count should be there. If it is yes, you will go ahead. If no, then you will not report this. And then you look for the clinical criteria, whether fever, urgency, frequency, all that is there. If it is yes, you will go ahead. If no, no, you will not report. Then look for the date of event and date of for the catheter also criteria is met or not. You see whether it is being satisfied, then you proceed further, otherwise you won't report. Then you report it as UTI, okay? Or again, based on your catheter criteria, catheter associated UTI or just a UTI. This is how the form looks like, UTI case investigation table. Same, whatever I just discussed, it will be there. It's somebody, you need a dedicated person who does this. You just cannot have a person who does the routine work and ask them to do this. It will never work out that way. It will be just an eye wash. So this is how I'm just showing the case report form of the various. Okay, you will also have to collect the denominated data here. If you want to calculate why you are doing surveillance, then at the end of this month, you would like to calculate your rates. For that, you need a denominator. So in this case, you will have to look for catheter days as well as patient days. What is catheter days? Catheter days is in that surveillance unit. For example, in medical ICU, think that it is a 20-bedded medical ICU. So number of patients which have been in that surveillance unit with the catheter in every day. Like 20 bed today, about 5 patients are on catheter. Tomorrow, 6. So today your catheter days will become 5. Next day, 6. It should be uniformly collected. Same time every day. Okay. Sometimes you will miss it, but that's why I'm telling you should be same time. Then only you get a uniform data. Otherwise, there will be a lot of biases in this. So every day uniformly, you see that a person who is going for the rounds have to collect this data. Or patient days, how you will collect? It is the number of patients who are there in that unit. I said 20 beds. If 10 patients are there, out of 10 patients, 5 are on catheter. Your catheter days become 5 and patient days become 10. Like that, every day it has to be calculated. So with this, you will be calculating your incidence rates for UTI. How do you calculate? Number of UTIs by number of patient days into 1000 gives your incidence of UTI. COTI will be number of COTIs by number of catheter days into 1000. And you can also calculate the device utilization ratio. How do you do this? It is number of urinary catheter days by number of patient days. So there's an example. I'm not going. I know how to. You know how to calculate. So we'll just skip this. So we are doing the surveillance at NIMS. This is the data, recent data. Total COTIs were 2, 1 from AMC, 1 from ERC. Not for the entire hospital. It's quite difficult. We have chosen from certain ICUs only. So UTI was 0. COTI, it was because of Pseudomonas and Escherichia coli, and the COTI incidence rate was 1 in this case. So this is how we are calculating device utilization ratio for the various wards or ICUs, AMC, ARCU, SSU. Month-wise, we take patient days and catheter days. So number of catheter days by number of patient days gives you a device utilization ratio. So if you see, where is it highest? It is highest in ARCU and then SSU. So device utilization ratio doesn't mean if the ratio is high, it need not be that the infection rates are high, because sometimes the device utilization ratio might be high in some ICU, but catheter associated infections can be high in some other unit. So here, if the ratio is high, means you can think that the infection practices may not be good when you're getting high numbers. So that is why it's not just numbers. The number gives lot of information. You'll have to think like whether they were introducing the catheter properly or not, the maintenance was done properly or not, whether the catheter was needed there, just they are putting. So this all information can be drawn from this data. So this finishes the UTI. Very quickly, I'll go to the, you want some break? 1-2 minutes? No? Can continue? Okay, thank you. Because these are the commonest infections, so I'm focusing on UTI and BSI. Similarly, you can also do for VAP and SSIs, but the procedure is little different, so I'm not discussing that here. So we'll go with the surveillance for BSI. So bloodstream infections, first you should know what is the timing of the blood culture. The optimum time should be before the onset of fever and chills, okay? Subsequent sample should be, actually what do you mean by a set? All of you use your bacterial lead system or still you use the manual method? Are you using the automated? Blood culture bottles you use for the blood? No? No? Okay. What do you mean by a set? We say all the times we say 2 sets, 2 sets, 2 sets. What do you mean by a set? Is it like based on the number of bottles or something else? Huh? What do you mean by a set? Set means a bottle. So if I say bottles, 2 bottles or 3 bottles you want to say set means? So set is not based on the number of bottles. It is usually when you're saying 2 sets means it should be from 2 different venipuncture sites. So the practice will be you just from single venipuncture site, you just draw the blood, put it into the number of bottles and give and call it as multiple sets. But that is not multiple sets. You should have it from 2 different venipuncture sites when you're giving, okay? So that, why? Because when you commensals will be there like cons. This is the commonest problem, coagulase negative staphylococcus. If you don't do the disinfection properly, you will end up with this skin flora. So if you don't collect these multiple sets, I'm saying 2 different sets, then you will not be able to conclude whether it is a pathogen or a commensal. So your practices also should be good. So first focus on the type, the blood collection part. It has to be done meticulously with all aseptic precautions, 2 different venipuncture sites, at least 20 ml of blood volume. With the higher amount of blood volume, the recovery rate also would be high. So here also it is the same. So since now you know the UTI, it becomes very easy. There's not much difficult. Only thing is here you have BSI, primary and secondary. There it was UTI, here it is BSI. There it was COTI, here it is CLAPSI. Central line associated bloodstream infection. Okay. Yeah, this I will focus. Sometimes, okay, laboratory confirmed BSI, when you're calling it as, you will be growing commensals. So commensals, you will have to be, no, commensal means what? The persons who doesn't know, especially for the nurses, I'm telling this, an organism which commonly exists on the body surface. Okay, it could be a contaminant. But anything, blood is so sterile, no? Anything just growing in blood, you cannot rule it out as contaminant if your collection was thorough. But if your collection is not good, then this is what you will be ending up growing only contaminants in the blood culture bottles. Okay. So recognized pathogen, you have a list of organisms which are recognized as pathogens. So then there is a list of commensals. So for a pathogen, just a single positive culture, you take it as a BSI. But for a commensal, at least it should be 2 or more positive cultures. And it should be the same organism. Okay, same organism growing in 2 or more. Not just in one bottle, one organism, the other bottle, other. Then you cannot take it as a BSI. Okay, and for a commensal, even the clinical criteria has to be met. You should have some symptoms and signs also there. Okay, this is about matching. When you're growing some commensals, you should look for matching cultures. So matching cultures, it has something to do with the time schedule. The blood cultures must be collected at the same time, or if it can be collected at different time, but on the same day or on the consecutive day. Only during this time, if it has grown, then you will consider it as matching cultures. Anything beyond that, then it cannot be called as matching culture. I've given an example here. For example, mitis from a peripheral blood, if it's drawn, collected on 20th October, matches with mitis grown from central line. So here 2 different lines, but same day. So you call it as matching culture. So mitis from central line at 6 a.m. on 20th October, peripheral line at 8 p.m. on 20th October. Different intervals of time, same day. Still it is a matching culture. Peripheral blood on 20th October, Then peripheral blood on 21st October, consecutive day. Still, it is a matching culture. Peripheral blood collected on 20th October does not match if it was collected on 22nd. It's not on the consecutive day. Then you cannot call it as matching culture. This is for the commensals. So this is how you will have to look for if it is a commensal. And then decide you have to report it or not, and then go ahead with the surveillance or not. Just look at this example. A patient has a blood specimen drawn from a central line at 7 a.m. on 10th November. Separate blood specimen drawn from a central line at 9 p.m. on 10th November. Both specimens grow micrococcus species. So do you call it as a matching culture? Yes. Patient's blood specimen collected on 15th November. It grows streptomyces. Additional specimens were collected between 16th and 18th June, which showed no growth. A blood specimen collected on 19th June grows streptomyces. Do you call it as? No. Can be even November also. Anyways. Also, look for the clinical symptoms. It is all based on the age. Okay. Patient more than 12 months of age, you will have to look for these. Fever or hypotension is there. If it is less than 1 year of age, the symptoms will be different. So you'll have to look for fever, hypothermia, hypotension, apnea, bradycardia. All this becomes significant then. So window period is the same based on the date of event, 3 days before, 3 days after. This is how you calculate 7 days. Microbiology lab calls you on 19 June to report that the blood culture collected from a patient in the ICU on 17 June is growing streptomyces. What is the window period for this potential BSI? Yes. Correct. Date of event? So for BSIs with a recognized pathogen will be the date of first blood culture collection. But for BSIs with a common commensal will be the date of first blood collection or the sign of symptom. Like if it is a pathogen, there you will not consider the clinical symptoms. If whatever the blood collected, that date you will take it as date of event. But if it's a commensal case, then whichever comes first. If the symptoms were first, that becomes date of event. If the blood was collected first, that becomes the date of event. That is how you'll have to calculate. Okay. Okay, you see this, same which I told you. So streptomyces from the previous example and find that the patient had a second blood culture with again mites on 18th June. Patient developed fever on 16th June. So first culture was on 17th, second on 18th, then patient had fever on 16th. So does the patient meet the BSI case definition? Yes. Clinical criteria is met, matching cultures are there. And then what is the date of event for this BSI? Because it's a commensal, you'll have to see whichever has come first. So it is the fever. So it becomes 16th June. For this also, you'll have to differentiate high or POA, present on admission, similar way which we have done for UTI. It's the same. Even time frame is also the same. Here also, you will have to look for the catheter criteria. Catheter here would be central line criteria rather than catheter. Similarly, like you for UTI, you had catheter criteria. Then clinical criteria if it's a commensal, and then microbiology criteria. So then based on that, you fill your BS report forms, and then you classify them, whether it is central line associated or not, or primary or secondary BSI. Primary BSI, what do you understand by primary BSI? The culture is only from the bloodstream in. Okay, you have only from the blood. Secondary means? Secondary to infection somewhere else. Could be secondary to UTI, secondary to pneumonia, secondary to some pus, wound infection, something. Okay, but then it should be a matching culture. The same organism should be isolated from urine sample and the blood sample. Then only you can call it as a secondary BSI. If it is a different organism, then you will not call it a secondary. So BSI categories just like UTI categories, primary, secondary, CLABSI, non-CLABSI. Here you have this secondary BSI attrition period. Here, how do you calculate this is from the date of event, 14 days before and 7 days after. So that period you take it as secondary attribution period. That means any samples which were sent apart from blood, urine or your tracheal aspirate, bronchial wash, any sample. And if it has grown the same organism, like which was isolated in blood, then you call it as matching and then you fit it into a secondary BSI. So that period is important. Only if it is during that period. Otherwise, we don't call it a secondary BSI. It will be a different event. Look at this example. You identify a BSI caused by E. coli in a patient in your ICU with the date of event of 2nd March. When you review the patient's chart, you find that a bowel specimen collected on 24th February also grew E. coli. Is this classified as a secondary BSI? Yes. Very quick responses from that side. Yes, why? How? Yeah, 14 days before. It's falling in that date? Yes. This is how the form looks. So this is how you will have to mark. Here, blood culture, this becomes your date of event. So this blue shaded thing becomes your window period. This is the time frame. Look at this example. A patient is admitted to your ICU on 10th July. Urinary catheter and central line are placed on 12th July. Okay. After 2 days, both urinary catheter is there. Now central line is also there. On 15th July, patient develops fever and also frequency. Urine and blood specimens were collected that day and sent for culture. Both urine and blood cultures grew E. coli. And also urinary colony count was more than 10 power 5. Patient is treated with antibiotics and symptoms resolve. On 23rd July, the patient again develops fever. Blood cultures are drawn and grow Enterococcus fecalis. What would your surveillance team report? Okay. So your date of event here it is 12. When this urine samples, yeah, yes. It's not a secondary BSI. So it will be a different event. Yeah, different organisms. Good. Okay, BSI that does not have a matching positive culture taken from another body side during the secondary attribution period is classified as primary BSI. And BSIs can be again classified into central or non-central. So you know what is central line and all that. We will not go into those details. So similarly, just like a flow chart for the UTI, here also you have this. First, positive blood culture. It's a recognized pathogen or a commensal. You will differentiate that. If it is a pathogen, then even a single culture positive, you consider that. If it's a commensal, then at least more than 2 culture were positive or not. If yes, then you look for the clinical symptoms. Any of this is present, then you will proceed further. If no, then you will stop reporting. Okay. Then look for the date of event. Then if it is a central line is placed, look for that. If it is, everything is falling into the criteria, then you report. Same, the form looks like this. This is how every day, this is an everyday job a person has to do, infection control nurse. It's not like whenever you want, you cannot do that. This is how the form looks. I'm showing that in different way. Similarly, for UTI, here also you have your denominators. You will have patient days and central line days instead of catheter days. This is an example. How do you calculate the central line days and patient days? Okay, I will discuss here. Patient has been in ICU for 3 days and has a femoral and jugular central line. Okay. The bed is empty until a patient, bed number 2 is empty until the patient is transferred from operating room. The patient has a subclavian central line. Bed number 3, patient has been in ICU for 2 days and has a PIC. Do you consider it a central line or no? Peripherally inserted central catheter, do you consider it a central line or no? It is considered as central line. Patient has been in the ICU for 10 days and had his femoral central line removed yesterday. Then bed number 5, it was discharged and did not have any central lines. We'll see. So for this first case, You have both patient days and central line days because patient is there in the ICU as well as he's having central line. But the next, the bed is empty, so no patient day. Since bed is empty and he was even the central line day will be 0. Patient has been in ICU for 2 days and also has PIC is also central catheter. For this, you'll have both patient days as well as catheter days. Patient has been in ICU for 10 days and then it was removed the day before only because we are not calculating a date of event. We are just calculating the catheter days. So here catheter day will be 0. Your patient days will be there. Patient in this bed was discharged, bed number 5 at 8 a.m. did not have any central line. So no patient day, no catheter day. This is how you calculate every day. That's why I said at particular time only, every day that person should go and do the surveillance. It is a full-time job. Then you'll have to calculate your LAPSIs and BSI rates. Here I've given an example, medical, surgical and pediatric ICU. The number of CLAPSIs from medical ICU, 3, surgical 4, pediatric looks like ICU. So looking at this number, what do you think? The numbers are more from? So, but then you will have to have the denominator. That's why I said denominator is important. So if you see the number of beds, pediatric has, the size is larger, 30. So when you calculate, your CLAPSI rate will be like this. So which is having high CLAPSI rate? Medical ICU. This is how you will have to calculate. How do you calculate the device utilization ratio? By number of catheter days by the patient days. So if you calculate for the medical, surgical and pediatric, it is very high for pediatric. Anything up 1 is very high. So it's almost 0.945. So how does this help? How do you prevent the infections? So if you look at surgical ICU, it has high CLAPSI rates and as well as high DUR. So you need to plan for some intervention. Unnecessary central lines, if it's there, you can reduce that. Pediatric, it has the lowest CLAPSI rate but highest DUR. That means unnecessary central lines which you can remove. This will in turn will reduce your rates. Medical ICU has highest CLAPSI rate but lowest DUR. Means what? Maybe some other factors. Your infection control practices were not good. Your insertion maintenance practices are influencing the rates. So you can focus on that and give the good training. This is how you can, this data gives that information. It's not just the numbers, what you're looking here. That's it. Thank you. Yes, you need a full time. And the nurse who is working in the hospital cannot do this. Only full time, only for this is possible. Yes. Yes. Definitely. The quality will compromise if the same person has to go here and he will not get the correct data also. Epidemiologist. Any questions? Thank you.
Thank you, Dr. Neelima, for your enlightening lecture on the CLAPSI and QARTI surveillance. But you need to cautiously do this surveillance. It's not so easy to imbibe in your minds. You need to concentrate. Once you get trained well over these definitions, it becomes easy for you slowly. Otherwise, you feel a bit dry to when the subject is going on. You need to repeatedly know about the definitions. So try to go through the PowerPoint later. Okay. And now I request Dr. Ram Mohan from microbiology. He's an associate professor. This is the last lecture, which is going to be on prevention of multi-drug resistant organisms. Sir, Dr. Ram Mohan, please come.
Thank you, madam. This is the last lecture for this training session, and this is regarding the prevention of multi-drug resistant microorganisms. So, for a successful prevention, a successful program, we need complete support of from the administration. The leadership has to be there, and as well as the financial and the human resource commitment. Just the sir has discussed regarding the availability of a nurse, full-time nurse who can monitor. So that applies here. So infection prevention and control, there are various factors involved in it. First, we need obviously the laboratory support. Whatever guidelines and policies we have done, it has to be strictly monitored adherence. It had to be adhered to, and then the monitoring has to be done regarding the adherence. Expert consultation has to be done, and finally the data analysis of everything. So for the epidemiological purposes, multi-drug resistant organisms are those which are resistant to one or more classes of antibiotics. So most commonly we have heard about MRSA and VRE. And also among the gram-negative organisms now, we are encountering mostly these terms CRE, CRAB and CRS, CRPSA, which is carbapenem-resistant enterobacterials, carbapenem-resistant Acinetobacter baumannii and Pseudomonas aeruginosa. These are very common gram-negative organisms which are notorious for their carbapenem resistance. So why are they important multi-drug resistant organisms? Obviously, we have heard in the previous lectures that with the occurrence of these organisms, the treatment options are very much limited. And the normal usage, antibiotic usage patterns, which are not completely monitored as per the guidelines, they suppress the normal flora, and which in turn creates a favorable environment for colonization of these multi-drug resistant organisms. And then this is actually called a selective advantage. And so these organisms, multi-drug resistant organisms, have been associated with increased length of stay, increased cost, higher mortality is seen, and these organisms are mostly seen in the ICUs compared to the non-ICUs. So there can be various factors which contribute to the varied prevalence of these multi-drug resistant organisms. The geographical various places where there are different antibiotic usages, different prevalences of this occurrences of these multi-drug resistant organisms, and also, as I told, the healthcare settings where the ICUs are more contribute more to the multi-drug resistance compared to the non-ICUs. So once they occur, what factors are responsible for this transmission and persistence of these resistant strains? So the selective antimicrobial pressure, colonization pressure, the vulnerable patients which are available there, and ultimately the impact of the implementation and adherence to the prevention efforts. All these factors contribute to the transmission and the persistence of these multi-drug resistant organisms. So in what way does selective antimicrobial pressure affect? As I've told, you constantly give antibiotics to a person, then the normal flora generally gets suppressed, and if there is a multi-drug resistant organism around, it becomes colonized, and then you have a lot of patients in a unit with colonization of these MDROs. And vulnerable patients, obviously, they are more susceptible. They can easily catch up these MDROs and they can sustain and maintain, and they can act as a source of transmission to the other patients. So the adherence, whatever we have learned the last 2 days, if these are not properly adhered to also, it contributes to the transmission of these MDROs. So vulnerable patients are those vulnerable patients to MDROs are those which have severe disease, who had a recent surgery, who have some indwelling devices in them, or with some underlying medical conditions like cancers or other conditions which can predispose to immunosuppression. So as per most of the studies, the colonized healthcare personnel, they have a limited role in the transmission of these MDROs, except when they are suffering from some obvious diseases like chronic sinusitis, upper respiratory tract infections, or dermatitis. In these conditions, they can also act as a source of transmitting these organisms. So mostly the source is from the hospitalized patients with more risk factors and higher infection rates. That is, the risk of acquiring VRE is if more than 50% of the ICU patients are colonized, then the risk of acquiring VRE becomes almost 50%. It's significantly increased. And also, we have heard that MDROs can also be transmitted from the healthcare personnel. They can be a source of transmission because of inadequate hand hygiene practices. So the various control interventions, they can be divided into various groups. First, the administrative support, judicial use of antibiotics, surveillance, which can be routine or enhanced, standard, following the standard and contact precautions, various environmental measures, education, and for some cases, decolonization with this is required for some MDROs. So the administrative support, we need administrative support in the sense that if an MDRO is detected in a unit, there should be some effective communication mechanism so that from the lab, the information reaches the ultimate caregiver, the unit where it is isolated. They have to get the information as soon as possible. And also adequate supplies of these hand hygiene scrubs should be there, as well as sinks. Everything should be provided at all the relevant places. And adequate staff who give the patient care, they also should be in adequate numbers. And strict adherence, enforcing the adherence to the infection control practices, hand hygiene, and all the standard and contact precautions. So we need to monitor whether they have been adequately adhering to all these practices which we have suggested. So it has been also seen in the previous lectures that direct observation is one method and giving a feedback whether the recommendations are being followed or not. And lastly, surveillance cultures, that there should be some adequate supplies and the laboratory should be adequately supported for carrying out these surveillance cultures whenever needed. So education can be either throughout the hospital, initially for all the staff, and also unit-wide targeted educational interventions can be done. If some unit is reporting a higher rate of MDROs, they can be repeatedly trained and bringing about the behavior change through better understanding of MDROs to enhance the adherence to these hand hygiene practices. So judicious antimicrobial use, as Radhika madam has spoken in her previous lecture, it decreases the MDR occurrence of the MDR gram-negative bacilli and restricting the broad spectrum agents only to the severe infections in unknown pathogens or avoiding excess duration of therapy. All these are obviously, we know that if we unnecessarily prolong the therapy, then also it can lead to suppression of the normal flora. Treating only infections and not the contaminants. That again is, that has to be some effective communication between the laboratory and the clinicians who just discuss which could, the organism which the lab is reporting, whether it's a contaminant or a just colonization, so that contaminants and colonizers are not treated at all. The strategies which can influence the antimicrobial practices are first education, restricting the formularies, already deciding as per the antibiotic policy what could be the empirical antibiotics for some specific organisms or specific infections. Antimicrobial cycling. Antimicrobial cycling is you select an antibiotic as an empirical therapy for some period of time. All the units for some particular infection, an empirical antibiotic is selected, and then for that time period, only that antibiotic is used as an empirical choice, followed by another antibiotic for the subsequent periods, so that this also could reduce the incidence of MDROs. MDRO surveillance is done, which it can be used to detect the newly emerging pathogens and to monitor the epidemiological trends of the rising antimicrobial resistance among the organisms, and to also measure the effectiveness of the interventions which I have already placed. So the various methods of surveillance are there, wherein the commonly used method is using antibiograms, which mostly they are being used. So this is just to this detects the emergence of new multi-drug resistant organisms, which was not detected previously, because as per the cultures which we receive, it could be within the hospital facility or wherever we are receiving from the communities also. We can detect the new trends in the emergence of MDROs. So this is mostly used to guide the empirical therapy, antibiograms. This obviously it's done from the routine cultures which we receive in the laboratory, microbiology laboratory. And MDRO incidence based on the clinical culture results can be done, which is based on the clinical culture results. So the culture results are guiding the surveillance method, and we cannot have any clinical correlation here. So the infection rates of MDROs can be also seen in various specific units in the hospitals. That also can be done. And molecular typing of MDRO isolates can be done to know the clonal transmission, whether all the isolates of the resistant organisms, if they belong to one, they have a one common source, then it could be suggested that they have come out from that the outbreak has occurred from one particular unit. So active surveillance cultures can also be done. This is actively we can take the surveillance cultures to know the patients who are colonized with a possible MDRO. So this combined with contact precautions can directly contribute to decline or eradication of the target resistant organism. So whom should we consider for doing the surveillance screenings? Already the patients who have an history of carbapenem resistant organisms either as a colonization or an infection, those patients, and the contacts of those known identified patients also can be taken. Patients with a history of hospitalization in an area where there has been an outbreak of these resistant organisms. And also patients who are admitted, the vulnerable patients also can be considered for active surveillance cultures, the immunocompromised patients. What should be the sample taken for the active surveillance cultures and what should be the frequency? Generally, for gram-negative organisms, feces are ideal compared to the rectal swabs and perineal swabs. Mostly, the most feasible sample for a surveillance culture would be a rectal swab. So, minimum one culture has to be taken at the hospital admission or at risk exposure. What is a risk exposure? So, surveillance cultures, either you can take it when the patient is admitted or else when some event has occurred. That means already you have isolated an MDRO at somewhere in one unit. So I told whoever have to be here in all these cases, that is a risk occurred, and that at that point you can take you can take a surveillance culture. And then you can repeat at weekly or bi-weekly intervals. It's not, there are no particular guidelines regarding the frequency, but you can do it at weekly or bi-weekly intervals. So in an endemic setting, like we can do active surveillance cultures for MRSA and VRE. But for MDR gram-negative bacilli, it's mostly suggested in an outbreak situation. So for this active surveillance culture to be successful, we have to have personnel who can take the cultures, lab which can process and give the results, and then the mechanism for communicating these results to the caregivers. Because once you have identified that some patient incidentally has either a colonization or an infection, we have to communicate to the relevant unit, followed by the precautions, either contact precautions or the precautions which have to be taken so that it doesn't transmit it to the others. So the last would be the standard infection control precautions have to be taken, as already it has been dealt with in detail over the past 2 days. Standard precautions and contact precautions. Standard precautions are what we usually follow routinely in our day-to-day caregiving. That is hand hygiene, which has to be again strictly followed, and contact precautions prevents the transmission of these infectious agents by direct or indirect contact with the patient or patient's environment. So this has to be implemented for MDRO colonized or infected patients and all new admissions or patients who have been admitted to the specific unit until the negative screening has for this MDRO is reported. So contact precautions, as it has been told, we cannot afford to have them in separate rooms like isolation. So all the patients with a similar MDRO can be grouped and cohorted in one either ward or one separate ward. And the healthcare personnel also could be dedicated who are attending to these patients. They should be dedicated to those, they should be giving care to only those patients. So these are the various contact precautions with that ensuring the appropriate placement and using the appropriate PPEs, and who enters and leaves and who are in contact with these infected patients have to be strictly monitored. And if possible, we need to use dedicated equipment for those patients. And strict protocols have to be followed regarding the cleaning and disinfection of these rooms. So the duration of the contact precautions, it's not very clear in the literature how long it has to be followed, because the MDROs can be, the colonization can be prolonged. So we are not sure when it has ended. Sometimes even if we take the cultures, we might miss, in spite of the patient being colonized, we might miss it in the cultures. So it's not exactly sure when we have to continue these precautions. But in an outbreak, we need to continue indefinitely till for all the previously infected patients and colonized patients are all the cultures are negative. In case of MRSA or VRE colonization, you have to continue till the patients stay in the setting where they first started. And if it can be discontinued if more than 3 surveillance cultures are negative over a period of 1 week, or 2 negative cultures in patients not receiving any antimicrobial therapy for several weeks. Considering that there is no obvious draining wound or a obvious profuse respiratory secretions or any other evidence implicating the specific patient in an ongoing transmission of MDRO. So the environmental measures, again, the environmental cultures are not routinely recommended for detecting these MDROs, but you can use dedicated non-critical medical equipment is one of the things which can be followed, and dedicating the cleaning personnel and increasing the cleaning and disinfection frequency. That is, as I told, the highly touched surfaces, we can be increasing the cleaning and disinfection of these surfaces at least 4 hourly intervals. Decolonization, it's usually for MRSA, it is done with topical mupirocin or a combination of mupirocin plus rifampicin or rifampicin and trimethoprim sulfamethoxazole or ciprofloxacin. Thank you. This is actually a gist of it's all whatever we have been talking, the same things which need to be followed, but specifically if an MDRO is there, it becomes an outbreak, and then we need to be particularly careful in isolating and cohorting them. If you have any questions to any one of the speakers also, you can ask, because it's the end of the all the sessions.
ఫోల్డర్లో వేసి
హెచ్ఎస్సి ఫోల్డర్ పేరు హెచ్ఎస్సి.
చెప్పేస్తాను. I thank you all of the delegates for attending this session and making it a grand success. I really appreciate your efforts. The way you have listened to the class was wonderful, and the questions you posed were also very good questions. And it shows us how much interest do you have in this. And really, we encourage you to give us a call if you have any doubts. And I appreciate all the delegates for attending this session and making it a grand success. So I thank all of you, doctors and nurses. Thank you very much. Thank you, sir. Thank you very much. If anybody wants to come to CSSD, please, we are taking you there. Please join us. If anybody are interested, please come with us to CSSD.
Good evening, everybody. I would like to thank Dr. Padmaja Madam and Microbiology Department and other departments too, and the NIMS faculty for conducting such a successful and refreshing training program for all the doctors and nurses. Thank you, Madam. Thank you once again.
Thank you, madam, very much, Dr. Geeta, madam. Nice to meet you all, the professors in anesthesia and every branch of microbiology. I met various professional healthcare workers here. Very nice to meet you all.
వాళ్ళు చెప్పారు కదా. ఓ మేడమే చాలు, నేను కాదు. మళ్ళీ నేను క్లోజ్ నేను చెప్పిన అనుకో, ఆ మేడం పద్మజ మేడమే కోఆర్డినేటర్. మేడమే వస్తారు.